Good morning and namaskar. It's a great pleasure once again to welcome you for the day 2 of Hematology Update, the updates from EHA 2023. It's a pleasure to have all the faculty here, and without wasting time, it's a pleasure to welcome and invite our program convener, Dr. Upendra Sharma sir. Everyone knows him well. He's a senior consultant hematologist and hemato-oncologist at the prestigious Bhagwan Mahavir Cancer Hospital, Jaipur. And we carry the greetings from the Pink City, Jaipur. Once again, good morning and a very warm welcome. The stage is set. Dr. Upendra Sharma, sir, over to you for the today's proceedings, please.
Thank you, Taranji, for that introduction. I am privileged to invite Dr. Farah Jejna, madam. She is professor and head Department of Clinical Hematology at prestigious PD Hinduja Hospital, Mumbai. She is my teacher, guide, mentor. Actually, she's a teacher for most of the students in the field of hematology. She has taught me ABCD of hematology, and she's doing that for other students also. I'm blessed with the knowledge of hematology because of only her. I invite Dr. Farah madam for her opening remarks and to start this conference. Over to Farah madam.
Good morning, Upendra, and thank you for inviting me here today, as well as to all the members who have joined in to listen to this wonderful program. As all of you are aware, this is an EHA update which took place this year, and today's meeting will be concentrating on two of the very common problems which as hematologists we see very often, and that is chronic myeloid leukemia and multiple myeloma. So we have distinguished faculty who will be giving you the update from EHA on these two topics, and also hopefully troubleshoot some of the problems that you might be facing in your day-to-day practice. It's an impressive program. I'm sure everyone is going to learn. And I must say, I feel very, very proud that at least a large part of today's faculty and maybe even yesterday's faculty, they all happen to be my students. So it really feels good. And they are all senior consultants, so it also makes me feel extremely old. But that I think is inevitable. So I wish all of you a wonderful session, and and thank you all for giving up your Sunday morning to listen to this session. And I hope everybody benefits from it. And once again, thank you, and have a great session and a great learning experience.
Thank you, Farah madam, for that inauguration speech. Now I invite Dr. Dinesh Gurani sir. He is Director, Department of Hemato-Oncology and Bone Marrow Transplant at prestigious Rajiv Gandhi Institute of Medical Sciences, New Delhi. Over to you, sir, for the next session.
Thanks, Upendra. Thanks for inviting me for your hematology update. Without wasting time, I'll invite Dr. Chandran K. Nair. He's going to be a speaker. He's a professor and head division of clinical hematology, Malabar Cancer Center. And he's going to talk on how to improve eligibility and success of treatment-free remission in CML. So, which is a real, we need a guidance into how to take the patients through this journey. Over to Dr. Chandran.
Thank you, Dinesh sir, and thank you, Farah madam. And I thank the organizers for giving me this opportunity. Hope I am audible and the screen is visible.
Yeah, make it this
yeah,
screen.
now it's a slide show, right, sir?
Yeah.
Yeah, so as sir mentioned, the topic for assigned to me is on how to improve eligibility and success rates for patients with CML who are being planned for treatment-free remission.
We are still not on slideshow.
Is it not?
No.
Now?
So click again. So please click again. I think we'll click. Can you just click again on the icon again?
1 second.
Yeah.
Now?
No.
Now I will do stop sharing and restart once.
Okay.
Now?
Yes, go ahead.
Is slideshow, right?
Yep.
Okay. So how to improve eligibility as well as success rates in case of treatment-free remission in chronic myeloid leukemia patients. My slides are not moving. My slides are not moving. Just sorry for the inconvenience. Just a moment. Is it in slideshow? Shall I proceed?
Yeah, proceed. Go ahead.
Yeah. So, as we all know, treatment-free remission in CML is a recent concept, especially put forward by two landmark prospective studies. One was the STIM trial, and second one, the largest one, was the EuroSki trial. And followed by which there were many published trials, and overall the treatment-free remission rates in all of these were around just below 50%. And the criteria for putting some patients into treatment-free remission, these are all well set criteria, like prolonged duration of TKI prior to initiation of stopping TKI, as well as prolonged deep molecular response. And obviously, patients should be ready for undergoing strict monitoring once a TKI is stopped. So these are the mandatory criteria. These are the criteria published by ELN in 2020. So which most of us follow, and they have put it in three different headings. One is called mandatory, second one is minimal, and third one is optimal. So this is also well known, but just to refresh things, I'm just going through this. So all the patients should be, who are all selected for TFR should be in first chronic phase only, and obviously they should be a motivated patient. And the most important thing should be a high quality PCR access, which should be based on IS reporting. And then even if there is an access, the turnaround time should be within the required limits. And patient has to agree.
Your slides are not moving.
No, I'm not moving, sir. Right now, I'm just reading this slide you're seeing, sir.
The first slide, you're on the EuroSki trial treatment-free remission rate of 45%.
It's not now?
No, the slides are not moving. Can someone share his slides?
Yeah, that's better.
Tarun?
Next slide.
Can you share sir slide?
Can go to the next slide. Yes, this is the slide I was talking about. So these are the set criteria by ELN published in 2020, where mandatory criteria says patient should be in chronic myeloid leukemia in first chronic phase only, and the patient should be a motivated one, and then there should be access to standard PCR monitoring based on reporting based on IS scale, and more importantly, there should be a rapid turnaround time. And patient has to agree for more frequent monitoring than the usual monitoring applicable for standard treatment of CML. With the monitoring, usually the standard standard is like it has to be on a monthly basis for the first 6 months, followed by every 2 months for the next 6 to 12 months, and thereafter it's like 3 months, once in 3 months. And then there should be some other criteria, like minimal criteria where stop is allowed. Like it should be like first line therapy or a second line therapy if the reason for second line therapy is an intolerance to the first line TK. And there should be typical BCR-ABL transcripts. And then another two important thing mentioned are, one is the duration of TK should be at least 5 years before considering stopping TK. And third one is duration of, second one is duration of deep molecular response, either MR4 or better, at least for a period of 2 years. So these are some of the standard criteria put forward by ELN for consideration of TFR. Next slide. And this I have already mentioned, the published landmark studies of STIM trial and Euroskis trial. They are the basic standards we all follow. And it is shown that the TFR success rates is usually around 50%, which implies that 50% will obviously relapse, regardless of the TK used in the front line. And most of the things are known about the recurrence rate in case of recurrence rate, as well as recurrence phenomena in case of TFR, because most of the molecular recurrences has been found out within the first 6 months of stopping TK. And the trigger for restarting therapy has been set as loss of major molecular response, that is which is equivalent to a BCR-ABL value of more than 0.1%. Next slide. So what are the current challenges? So basically the topic is like how to improve the TFR rates, as well as how to improve eligibility also. So then we should know the current challenges in pushing patients for TK. Obviously, we know that in any patient, newly diagnosed patient of CML, the achievement of DMR, deep molecular response, like MR4 or better, happens in around 40% of patients only. And we know that the standard TFR rate is always around 50%. That means half of this 40% only can be considered for, or will have a successful TFR, which is around 20% of the entire number of patients being considered in the beginning. So which is like very, very less number when we consider the a newly diagnosed patient of CML. Their successful rate of TFR could be as low as 20% only. So then the question comes, how to overcome these difficulties? So how can we push more patients for better DMR, and then how can we sustain the TFR rate so that the overall success rate of a TFR becomes much higher than this 20%? So there can be two ways to improve the chances of TFR. One is to increase the rate of durable DMR. So in general, as I mentioned, it is only 40%. Can we have more deep molecular responses so that more patients can be pushed for TFR? And second one is, once a DMR is achieved, so there is a concept of functional cure these days in CML. Especially we know that the molecular relapses in case of CML happens from the quiescent CML stem cells, which is actually not very much suppressed with the conventional TK that we give nowadays. So if there is a possibility to suppress the CML stem cells also, so that there can be a situation of operational cure or functional cure. So these are the two areas where one can work on, so that the chance of TFR as well as success of TFR can be increased. Next slide. In those published trials, there were a few predictors of success already described. So obviously one can try to find out such patients who already have these types of predictors, so that we can have a better TFR rate. And one predictor of success in both Euroski trial as well as STIM trial was a longer duration of TKA prior to stopping it. So that was highly predictive. And second one is, most important factor was the duration of deep molecular response. So if deep molecular response, at least 2 years is recommended, but if it is beyond that, the chance of successful TFR always becomes better. Next slide. And can we select patients right from beginning based on a few parameters, so that their chance of TFR becomes high? So one example mentioned is the so-called score, which was shown in STIM trial, that people with a low so-called score are going to have better TFR rate compared to people with intermediate to higher so-called score. From the picture, what we can see is those people with the lowest so-called score, that is a red line, the TFR rate is anywhere above 55 or near 60%. Whereas people with higher so-called score, the TFR rates becomes as low as 10%. So there is an option of selecting individuals with a CML, newly diagnosed CML, with a low risk so-called score to consider for TFR trial, so that their success chance could be improved. Next slide. And this is this we all know that use of second generation TK when compared against first generation, that imatinib, it produces rapid and deeper responses. And a few 2-3 slides ago, I mentioned that one of the important criteria or predictor for having a better TFR is always a better deep molecular response or higher deep molecular response. So what we can see is in the randomized controlled trial, that's NS10 trial, where nilotinib was compared against imatinib, the major molecular responses at 1 year was much higher in nilotinib arm compared to imatinib arm, as well as the time to achieve the major molecular response or deep molecular response was much shorter in nilotinib arm. Similar result was shown in the decision trial, where dasatinib was compared against imatinib, and MMR rates was much higher, much superior compared to imatinib, as well as the time to achieving deeper responses were also shorter. So the conclusion was both the second generation TKA achieves faster responses as well as deeper responses when compared to imatinib. So this could be one of the options, like trying second generation TKA in the upfront to push more patients into deep molecular responses, and then trying for better TFR. Also, they are achieving the deep responses are much faster compared to imatinib. Next slide. So this table shows summarizes some of the things I have already mentioned and a few more things also. So which actually tells what are the methods, one to improve the eligibility of TFR. Second one is once a TFR is achieved, how to make it more stable. So prognostic score, so-called score, we have already spoken. It actually improves the eligibility as well as it improves the stability of TFR. TKA type we have mentioned because second generation TKA are better in improving the deep molecular responses. But we all know that there is no major difference in the TFR outcome, the percentage success rate of TFR when 2G TKA versus first generation TKA is compared. Then there is a concept of rapid decline in the BCR-ABL transcript level, which is otherwise called early molecular response. Then it has been found that people with a very rapid decline in BCR-ABL transcript level, the probability of achieving deep molecular response is much better than people who don't have a rapid decline. So that means more people can be pushed into DMR early so that their eligibility for TFR improves. But this does not translate in the successful stability. Then role of achieving MMR at 12 months, again something similar to rapid decline. So probability, if somebody achieves MMR at 1 year, their chance of achieving deep molecular response also improves. Then another point or predictor of success in case of eligibility of TFR was a type of transcript of BCR-ABL. The conventional transcript of E14A2 was found to be much better when compared to E13A2 with respect to both eligibility of TFR as well as success rate of stability of TFR. So those are some of the factors responsible for eligibility success. Whereas there are a few more factors which predicts a stability or final success rate of TFR, like duration of deep molecular response, which I have already mentioned. Obviously, it means longer duration of deep molecular response before stopping TKA. There is a longer chance or better chance of stability of TFR. Then the level of molecular response before stopping. So if say MR4, MR4.5, MR5, so at the depth of response improves, the chance of TFR also, success rate also improves. Then duration of TKA already I have mentioned. And there are some immunological mechanism also which has been recently found out in predicting the success rate of TFR, which we'll be dealing with the next slides. Next slide. Now, these were the conventional approach according to the published trials on how to predict the successful chance of a TFR. But there should be some innovative approaches so that more people can be pushed into deep molecular response and then into the chance of potential cure. So when we talk about those types of innovative approaches, there are a few molecular mechanisms always comes into consideration. One is a JAK pathway, where in the picture what we can see is a CML stem cell line, which actually depends on two different pathways. One is a BCR-ABL, which we all know as a conventional, and second one is it always depends. Means it also depends on another pathway called STAT3 pathway, which is usually stimulated by a JAK1 kinase. And we know that we have available JAK inhibitors, like non-specific inhibitors, right, like ruxolitinib. So there is always a prospect of combining this JAK inhibitor along with BCR-ABL inhibitor, that's TKA, so that the entire CML stem cell itself can be completely shut down, so that we are aiming for a potential cure. So this type of clinical trials are going on. A combination of TKI with ruxolitinib is going on, so that upfront this is being tried, so that more patients are being put into deep molecular response to the point of potential cure, so that their chance of TFR could be improved. Next slide. Similar to this JAK pathway, another pathway is a BTK pathway involved in maintenance of CML stem cells. So what is found out is the CML stem cells also derives signals from the FC gamma receptor 3B, and the phosphorylation of which happens through BTK pathway. So, and this phosphorylation is important in maintaining CML stem cell lines. So again, just like JAK plus TKA inhibition, there is a prospect of administering BCR-ABL inhibition, which is a
kindly
TKA.
conclude your talk in 2 minutes, please.
Yeah. So this is like 2-3 slides pending. And then combination of BTK inhibitor along with TKA, so that CML stem cell lines could be suppressed. Third one, next slide. So another point is the BCL2 expression on CML stem cell lines. It has been found out that more BCL2 is being expressed on CML stem cell line. So similar to other two prospects, the combination of TKI plus venetoclax can suppress CML stem cell lines. And this study is already going on, and it is completed. Results are awaited. A combination of dasatinib plus venetoclax. Next one. And the last point is, as I mentioned, there is a derangement in, there are some connections with similar cellular immunity along with TFR. And it is found that people with successful TFR have higher numbers of natural killer cells and lower numbers of both regulatory T cells and plasmacytoid dendritic cells. So a combination of TKA along with interferon or checkpoint inhibitors like nivolumab can alter the immunological scenario in a patient's CML, so that successful TFR could be achieved. Next one. So to summarize, certain requirements for pushing patients to TFR are crucial, which I have already mentioned: the PCR monitoring, motivated patients, etc. And then to improve the TFR rate, one could be considering second generation TK in the upfront setting, as well as innovative approaches, just like the JAK inhibition, BTK inhibition, and then combination of venetoclax with TK. Those could be the future. Thank you very much.
Thanks, Chandran. Sorry, we have don't have time for the question and answer. I thank the speaker, Dr. Nair. And with this, we'll go to the another session. It's by Dr. Riaz Ahmed. He is my colleague from Delhi. He is a hemato-oncologist, Max Super Specialty Hospital, Saket and Gurgaon. He'll be talking on chronic myeloid leukemia, unmet need, and treatment landscape. Dr. Riaz Ahmed.
Good morning, sir.
Yeah.
Someone can share my slide?
Can technical team help?
Yes, sir.
Please help him.
भैया सर
Yeah.
आपकी स्क्रीन पे ग्रीन कलर का ऑप्शन होगा सजेशन का.
So let me do this. I'll share. Is it visible now?
Yeah. Just go under the slideshow.
Yeah. Is it there?
Yeah, go ahead.
So thanks, Upin. Thanks for having me here as a speaker, and thanks to Dr. Brani. Dr. Nair has completed almost what the unmet need. So aggressive monitoring, novel therapies, or in combination, or upfront second generation TKI. That's the thing which we are considering in CML. So as with the advent of first generation TKIs, we knew that the imatinib has been very good. Almost 70-80% are in CCR, having a long-term overall survival. But there was some 20-30% patient of the patient who required, who didn't were unresponsive or who had failure and requiring the second generation. And those who have failed first line then went to the second line TKIs. And from those TKIs, again, we had some. So the population of those CML are less as compared to the first line, but they are quite significant because the response rate of these TKIs after failure is not same when it used upfront. So the failure rates of successive TKI treatment in patients with newly diagnosed CML, if you are using frontline imatinib, or the failure rate in the frontline imatinib could be 31%, and in the second generation it can be as low as 13%. So that's the data. And when you do the second line, when you have failed, the group of patients which have second line failure, and you have asked the second line, the failure rate can be as high as 50%. And on the 13% of the patient, those who have second generation started upfront, the failure rate can be as high as 60% patients. So we know that there is an unmet need with each line of ATP binding TKIs, failure rate increases. Thus, the novel treatment options are needed for the patient in whom more than 2 prior TKIs have failed. And the third, is the increases. So imatinib in the first line, 31 to 50 to 75, and the second generation, you can see that the failure in the 13 to 60 to 80% is there. So what can be done to prevent this, and what leads to this emergence, the failure rate? The patient that have new mutations in later lines of therapy have few treatment options due to limited sensitivity of remaining TKIs. So in this small study, what they were done is a mutation analysis was performed following failure of imatinib, and again during the treatment with second line or third line therapy with a second generation TKI. So of which you can see there 24 of 61 developed more than one new kinase domain mutation, and 11 patients lost more than one kinase domain mutation while on their second generation TKI. So this is what happens when you have exposed to the first generation TKI, and while on the second generation, the chances that you are going to develop new mutations are even greater. So hitting early with the second generation, as told by the previous speaker, that it may be the norm of the society. And we have seen in our clinical practice when we are using the second generation TKI upfront, the results are better as compared to the first generation TKI. So the patients in their later line of treatment have reduced overall survival. So I'll come to this. I can't move these slides. Yes. So in this study, when we see that when the first line, it was the overall survival was treated with first line imatinib followed by either dasatinib or nilotinib. For the patient requiring second line or third line TKI therapy, the overall survival in 5 years decreased from 82% to 77% respectively. And in 3 line, it reduced further. So we know that this is the in this the different site. The first generation have different site of the ATP binding sites indicated by the red circles. So as you go up on the second generation, third generation, the number of the active sites of mutation, the site target of targeting the mutation is more. So this is the slide which depicts the TKI intolerance for discontinuing the CML therapy. So although adverse event may be adequately managed by dose reductions or interruptions in TKI trials, many patients discontinue therapy due to intolerance. Now, what we see in the trials and what we see in the real world, it's little different. We see more commonly, we see intolerance, we do see failure more common. So what the trial says, in the first line in the IRIS trial, 5 years in the 5 years follow-up, the discontinuation was 28% as compared to the nilotinib in the NEST and 31% in the dasatinib. It was almost the you can say 39%. So and the Bela and the before for the bosutinib 37 and 22%, and the discontinuation due to adverse event were in the imatinib arm were less, but if you can see the second generation when has been used in the nilotinib or the dasatinib or the bosutinib, it was almost in the range of 15 to 20%. And discontinuation to the disease progression was not reported in the imatinib, but it was 4 to 11% in the bosutinib and the dasatinib arm. And if you are going for the second line treatment upfront, so you can see the discontinuation in the range of 70%, and the due to adverse event or the disease progression, you can have the 20% to 30% respectively. And in the third line or P315 mutations, the discontinuation was as high as 30%. Adverse event was 30%, and the discontinuation due to disease progression was 21%. So treatment goal of CML, as we have seen in the previous, the treatment goal of CML still remains the same. So patient with having a complete cytogenetic response, deeper response, longer survival without any adverse event, and also the quality of life of the patient should also be better. And also the burden of the treatment cost should be low. So it's not only that they should not, the medically the disease, the adverse event is less, it's also the cost and the other quality of life remains better. As the patients are living longer with the advent of TKI therapy, the quality of life has become more important treatment goal. The patients with newly diagnosed CML-CP may wish to strive for early, what we see as EMR or a deeper molecular response, with the goal of attempting TFR, which may be particular importance of the patients of reproductive age. For the patient receiving their second line of therapy and beyond, the treatment goals include prevention of disease progression and achievement of complete cytogenetic response or major molecular response within 12 months after first line therapy. And also in resource-poor countries, the availability of effective drugs and essential monitoring may be limited, and the goal of treatment remains the survival. So what we see is that rate of treatment failure with current available TKIs increases with each line of treatment. Current third line TKIs have off-target activities that can lead to long-term safety issues, and sequential TKI is associated with increased resistance. So what is the need for new therapies for the patient for T315I mutations? So T135 mutations, you all know, so the worst thing a CML patient can have, and these are common with CML, these mutations common with CML-CP resistance to imatinib. So patient with T315 mutations have poorer outcomes as compared to the patients without mutations. The patient without BCR ABL1 mutations, the 91% overall survival in the rate of 91%, and the overall survival of the patient with T315 mutation was 71%. Also, they may require not only the drug, which is also this may be attributed that the patient progressed and gone transplant and TRMs and the relapse occurring in these type of patients. So unmet need for the patients with T315 mutations, treatment options are limited with this BCR-ABL1, T315 gatekeeper mutations. the patients with T315 mutations have poorer outcome than the patients without mutations. Also, in the monitoring, due to difference in this is the what we have been the NCCN guidelines every 3 months and then every 6 months, initially every 3 months for 2 times and then 6 months to be monitored regularly and in the NCCN and the ELN guidelines. So real world evidence demonstrate that the molecular monitoring guidelines are not always followed. And also when we are talking about the TFR when we are using, what is the level at which we are doing? What is the different so-called score? There may be different factors that whether the patient was high risk, low risk, what was the molecular response when the TFR was initiated. So how often it was monitored, how stringently it was done. And the recommendation between NCCN and ELN are inconsistent. There can be difference between the laboratories due to lack of harmonization of these standards. So UTOS is another collaborative effect between this Novartis and the ELN to standardize the molecular testing that has been implemented. Although the real world evidence, especially in the country like us, when we don't have the labs collaborating or the BCR-ABL level correlating with the another lab, this can be a challenge. So the target response milestones for the first line and the second line TKI therapy as per the ELN recommendations, we know this, that going to the 3 months, it should be less than 10%, 6 months should be less than 1%, or 12 months less than 0.1%, that is MMR. And anytime it should be less than 0.1% to have, say the patient is. So what, this is the warning signs when you don't achieve the target and you are on the first line going to the second line therapy, or you have to change the therapy going to the warning, and the finally you have to give the patient what the best TKI. This can be a guide to what you are going to start. So deeper molecular response is associated with improved outcomes, we all know. So decreasing the proportion of BCR-ABL percentage less than 1% at 12 months. CCR is correlated with better overall survival. At the 12-month, MMR is correlated with better PFS and overall survival. And MR4, 4.5. Again, the is correlated with the lower risk of disease progression and death, and is criterion to attempt the TFR. So with this can be in if prospective studies to done whether the TFR was attempted as MR4 or MR4.5. The differences can be there. How long the patient was in MR, the duration, that which what was the risk category at initial, that can also be criterion to what the patient has achieved, and that may come up in subsequent year. So deeper molecular response may be associated with reduction in disease progression and improvement in survival. And we can see as the depth of response goes low, or if you can have the depth of DMR at prolonging for 3 to 5 years, if you're achieving MR4, MR4.5, the survival increases. Early molecular response, which may predict the subsequent outcomes in patient with CMR. So early molecular response are less than 10%, or equal at the 3 or 6 months is an established target. And achievement of early molecular response may predict OS, PFS, and deep molecular response. So in this disease state, the patient with CML treated with TKI therapy have a like expectancy comparable to the of general population. Over time, treatment goals have evolved from the survival to prevention of disease progression, improved quality of life, and TFR. So not only the disease should be having, you should achieve these goals. The quality of life is important. The money, the expenditure that is spent also should be taken care of. So quality of life and economic burden, just a few slides on this. In the patient with CML, quality of life worsens by disease stage and the line of therapy. So as you change from first line to second line, in the case of failure or disease progression, the response is not that great. And also the response you may achieve is only 50% of the cases, and patient may progress on that, or the patient may have more adverse events. So quality of life is significantly lower for patient receiving second line or third line treatment compared to first line. And these differences were determined not to be clinically meaningful due to small. So upfront, when you are using the second generation TKIs, and which have early molecular response or deep molecular response, the quality of life is much better for those patients as compared to the patients who have failed first-line therapy and moving to second-line therapy or second-line therapy, third-line therapy, the quality of life can be tough for these patients. Also, the healthcare cost, not only in India, also in the Europe, on the cost of these drugs, which the newer drugs which are coming, plays a significant role. The second generation or the third generation molecules may be adding to the having a bigger budgets, and that affects the patients' availability, patients' ability to have these drugs on board. So the healthcare cost increases after each line of TK therapy, and this is the claim database used to form the HCU cost of a year after failure of each line of TK therapy in patients with CML. The average cost in the year after treatment failure increased by the line of therapy. You can see the $78,000 to $99,000. So after each, we know that the second generation, we are lucky to have the generics, but the places where they don't have the generics, the cost can be really high. So in the real world, the CML cost increases as told in the previous slides, nothing much in here. So coming to the summary of this rate, the quality of life decreases by increasing the line of therapy with progressive disease. The health care cost increases for patients with progressive disease compared to the patients who do not have progression. Healthcare cost increases by the line of therapy. The rate of treatment failure are currently available TKIs increases with each cost. Currently, third-line TKIs have off-target activities that can lead to long-term survival.
Kindly conclude your talking.
Yeah, so this is the conclusion. So, and the regular, sensitive, and robust molecular monitoring is required for evaluating and quantitative treatment response, and that can be harmonization is the need. And as the patient may remain in TKI for many years, reducing adverse events and improving quality of life has become important treatment goals, and there need to be structured monitoring in patients. With this, I conclude. Thank you very much.
Can I ask whether is there any time we have? Do we have a time for one or two questions?
Yes, sir.
Huh?
Yes, sir.
Yes, sir. Okay. Okay. So can we have a quick questions? Anyone wants to ask? Anyone from the audience? I just want to make a comment. We have become slightly loose with the treatment of CML. We say don't worry, and still the number of people going into the blast crisis and going to the third line have not decreased. So we are not able to make the people more curable by having more lines of therapy, because this is oral therapy, requires a long-term commitment, and our emphasis is not that much than the other cancers. Any other comment or questions? I can't see any other questions. So this I'll hand over. Thanks, Riyaz. Thanks, Dr. Nair. With this, I'll hand over to the technical team for the further proceeding. Thanks for inviting me.
Thank you, Dr. Riyaz, for that wonderful talk on the CML, unmet needs and treatment landscape. Thanks, Dr. Budani, for chairing the session. Now I invite for the panel discussion. To moderate this panel discussion, we have Dr. Pawan Kumar Singh. He is head Department of Hematology and Bone Marrow Transplant at BLK Max Super Specialty Hospital, New Delhi. He will be moderating the next section on this topic. So over to Dr. Pawan. You can introduce your panelist. Dr. Pawan. Are you there?
Yes. So thank you, Dr. Upen. Thank you, organizers, for inviting me for this session. So I think my slides are visible.
Dr. Pawan, you can introduce, or I will introduce your panelist.
Yeah. So just please introduce because I don't know who all are available.
Sure.
I know the panelists, but
so now we have for panel for panel discussion, we have Dr. Kundan Mishra. He is a senior consultant at Department of Clinical Hematology and Stem Cell Transplant, Army Hospital, Lucknow. We have Dr. Govind Patel. He is an associate professor, Department of Clinical Hematology at Dr. SN Medical College, Jodhpur. We have Dr. Shishir Seth. He is senior consultant hematologist and hemato-oncologist and bone marrow transplant physician at Apollo Indraprasth Hospital, New Delhi. We have Dr. Prakash Shekhawat. He is my colleague. Is a senior consultant hematologist and hemato-oncologist at prestigious Bhagwan Mahavir Cancer Hospital, Jaipur. We have Dr. Surendra Beniwal. He is professor and Head, Department of Medical Oncology at PBM Hospital, Bikaner. We have Dr. Amita Ramaswamy. She is Senior Consultant at Hematologist and Hemato-Oncologist, Bone Marrow Transplant Physician at Action Cancer Institute, New Delhi. Over to Dr. Pawan for this moderation.
Yeah, thank you, Dr. Upen. Thank you for helping me out in the introduction of panelists. So in another next, I think we have 25 to 30 minutes. So we'll be having a panel discussion. I've selected two interesting cases. And based on that, we will enlighten our knowledge with our expert team of panelists. And so this is the first case which I want to start. So this is 30-year-old boy, 30-year-old gentleman who presented with 4 months history of loss of weight, significant loss of weight, around 8 kg. There were no other complaints. So for this, he got evaluated and found to be having high TLC. So this was in January, early January, and late December and early January. So when he came to me in 24th of February, so at that time, the examination findings were this. We'll be having this in our later discussion, the significance of this. So at that time, so almost 1.5 months later, so mild pallor was present and there was no organomegaly or lymphadenopathy. So this was the investigation, the CBC report. I've selected only the CBC and other relevant investigations. There are no other significant laboratory abnormalities. So on 29 December, his TLC was 1,18,000 with normal hemoglobin and platelet count. The differential count was, there was shift to left. So it was looking like CML. So with this, now I want to start with my first panelist, Dr. Kundan. So at this CBC, so what investigation do you prescribe now, seeing at this CBC report?
Yeah, am I audible, sir?
Yes, you are audible. Please go ahead.
Yes. Sorry, actually, I'm traveling, so maybe some issue with my voice and other things. Anyway, so with this case as such, the CBC and the kind of differential is there. It does look like one of the MPN. And if clinically I find that patient has a spleen also palpable, then my clinical conviction will be more that most likely this case has got CML. So apart from the routine test, what we do, RFT, LFT, LDH, viral markers and all, I would like to get BCR ABL done. The first, usually we get it done by RT-PCR only. And also I'd like to get a bone marrow done for the patient. Apart from that routine investigation, I'd like to get usually an ultrasound of the abdomen and one chest X-ray. So usually this much is sufficient for most of the patients of CML to diagnose with. And on bone marrow sample, I'd like to get the karyotype also done. So this completes usually our initial workup. If patient comes out to be BCR LBL positive, nothing much to do. If in case it comes out to be negative, then there are further things, because clinically I think this is CML and young patients, CML will have lots of benefit for him in comparison to BCR LBL negative MPN. So in those cases, sometimes you go for fish or even NGS. So I think that's what we do usually.
Yeah. So my next question is to Dr. Govin. So do you prefer to do PCR test on bone marrow sample or on peripheral blood sample?
I prefer to do BCR ABL on the peripheral blood sample, but nowadays I've changed my practice, and in every patient at the diagnosis I do the bone marrow. So I do nowadays I do the BCR ABL on the bone marrow sample, but we can do it on the peripheral blood also.
So is there any data or any difference when we do it on bone marrow or peripheral blood?
No much difference, because sensitivity of the PCR is very high. So we can do it on both sample, peripheral as well as bone marrow.
Okay. So now my next question is to Dr. Shishir Seth. So Dr. Shishir, do you recommend bone marrow test at diagnosis for every patient, and any preference, any reason for that?
So generally, we are not doing a bone marrow test for each and every. Only the patient from blast in peripheral blood.
Your voice is not clear, Dr. Shishir.
Yeah, so we are not doing a bone marrow test for each and every patient. generally we are reserving bone marrow for the patient who means peripheral blood is showing means blast. So to know the exact number of blasts, we are doing bone marrow test. Or sometimes means people where the means PCR that is means come negative. So just as an NPM backup means we are doing bone marrow because sometimes very few people they have means some different transcript, especially very rarely we are seeing transcript 230. That is usually we had seen not detected by PCR, though they are writing they are detecting 230 also. But my experience is 230 transcript that miss. So I generally reserve bone marrow for few selected patients, not for everyone.
Okay. So Dr. Prakash, do you agree with that? Do you do bone marrow for every patient or only few cases as Dr. Shishir has mentioned? Dr. Prakash Shekhawat?
Dr. Prakash, you're muted.
Yes, sir. My practice is to go for baseline karyotype. So I advise bone marrow for every patient. But I spare those few who are very elderly and I think they won't be going very high with their treatment. Otherwise, bone marrow for everyone, especially for the karyotype purpose.
Okay, the same question to Dr. Amrita and Dr. Surendra Beriwal also. Do you prefer to do bone marrow for every patient?
See, ideally speaking, bone marrow aspirate and biopsy should be done in each patient at diagnosis. But then, see, when I was a DM student in AIMS, given the numbers of patients of CML, we were not doing a bone marrow aspirate and biopsy in every patient in CML. But ideally speaking, we should do a bone marrow because we can send the karyotype on the bone marrow. And I do agree with Dr. Prakash, if the patient is very elderly, means 70 plus and above, I mean, you may not do a bone marrow in that patient and do a BCR-ABL on the peripheral blood.
And Dr. Beniwal? So Dr. Amrita, what diagnosis which method do you prefer for doing CML? It's not PCR, whether it is PCR, FISH.
Okay. So some people, some pathologists, they tell us repeatedly, I'm sure Dr. Vikrant used to tell us repeatedly that at diagnosis, it should be a qualitative PCR and not a quantitative PCR. The advantage of a qualitative PCR is it will tell you the different type of transcripts, and if it is an unusual transcript, a qualitative PCR will pick it up. But ideally speaking, both quantitative and qualitative should be done. But given the fact that the usual quantitative PCR picks up both P190 and P210, I think I do only a quantitative PCR at baseline for most of my patients. Ideally speaking, both should be done.
Okay, fair enough. So, so I'll just go back to my case. So this was on 5th January. So seeing at this picture, so it was in earlier, this patient was in follow-up with the medical oncologist. So this test was done, BCR-ABL was done, and it was done from Max Saket lab, and it came negative. So patient was started on hydroxyurea with that high count. On 19 January, again, the TLC dropped down to 20,000. The differential is not available. And his MPN reflex panel, JAK2, CALR, MPL, all were negative. And repeat PCR was again done. And that was also came as negative from the same lab, Max Saket. So patient continued on hydroxyurea. And this was then on 24th January. So these are the differential, almost like looking like normal differential count with a TLC of 11,600. So this was on 24th January. But on 17th February, the TLC again jumped up to 1,88,000. So with the slight mild anemia 9.9 and platelet count 5,75,000, differential count showing left shift and the basophilia of 7%. So at this point of time, so my next question to the panel is Dr. Kundan. So what would you like to do in this patient at this point of time? 2 times PCR done negative, TLC now gone up to 1,88,000, bone marrow not done. So how you are going to approach this patient now? Dr. Kundan?
Hello.
Yes, Dr. Kundan, please. How you are going to approach
sorry.
this patient now? Now the TLC has gone up to 1,88,000.
So it came down to normal and then it has gone up. No, sir. This is what I understand.
Yeah, that was because of hydroxyurea and 2 times PCR done negative for BCR-ABL.
So in a known case of CML,
no, still he is not diagnosed as CML.
He is not diagnosed as CML. Okay.
PCR 2 times done, PCR negative.
Okay, so I missed, I think, few slides in between because I was driving, as I told you earlier.
Yeah, these are the slides.
Okay.
2 times PCR done.
Okay. 2
So
times
TLC
PCR done.
dropped down to 11,000 because of hydroxyurea. Now again the TLC gone up to 1,88,000.
And patient is still on hydroxyurea.
Patient is still on hydroxyurea, yes.
Okay. So while on hydroxyurea, if count is increasing and in peripheral blood smear, there is no blast and all coming. Or there are some blasts. Can you see something?
Yeah, blasts are there. Left hip is there.
Left hips are there. 1% blast.
Basophilia is there.
Yeah. So still, I think this seems to be a case of CML only to me. If bone marrow was not done, I'd like to get the bone marrow done to see how is the bone marrow milieu. And at the same time, if you have not been able to pick it up by BCR-ABL, I'd like to go for fish, or maybe even if it is not fish is also not picking up. These days, NGS is also picking many other variants. This is what I have come to know, that earlier we were only talking about P190, 210, 230 kind of things. Nowadays, there are some other variants also which are being picked up by BCR-ABL, which are being picked up by NGS, and which is responding to imatinib. So maybe NGS will also be required in this case, and bone marrow for karyotype, as all the esteemed, all the panelists have discussed, that getting a conventional karyotype, and many of the pathologists are also of the opinion that when you are missing BCR-ABL, it is better to do a conventional karyotype and see many times we will be able to pick up. So perhaps a bone marrow, karyotype, and an NGS. Fish maybe, somebody may also go for fish, but I'll prefer these days NGS rather than fish.
Okay, so I think most of the panelists will agree for this thing that we need to do a bone marrow test now. So on 24th, this patient came to me and we did a bone marrow, and bone marrow aspirate biopsy was consistent with CML in chronic phase. So cytogenetics which we did, and it was reported as 922, all 20 metaphases from Max Saket lab. Then on 1st March, the report, because after seeing this cytogenetics report, so we did fish, and fish was 90%. This was reported from Lal Path lab. And then he was started on imatinib. So after starting imatinib, so this patient, so on 13 March, the TLC came down to 5,900 and with almost the normal difference. And the PCR, I want to emphasize here, it was done on 1st of March, and then it was repeated twice. So they did 2 runs, and all this time also from Lal Path lab also the PCR came as negative. So now my question is to Dr. Govind, how many of the panelists, in fact everybody can take this, whether we do routinely for fish testing or not?
No, in our practice, I don't go for routine fish.
Okay,
we are also not doing the fish at the time of the diagnosis. If we clinically suspect strongly, it can be a case of the CML and BCR-ABL is negative, then we go for the fish along with the bone marrow cytogenetics.
Okay, Dr. Shishir.
So yeah, means in case of if the PCR is negative, then means we are doing bone marrow karyotyping and surface examination, because as discussed, that means few rare variant, they are not picked by PCR.
So this patient is now the only test which is abnormal is the fish and the cytogenetics. So all 20 metaphases showing translocation 922. Now my next question is to Dr. Prakash. How you are going to monitor this patient?
Apart from clinical, for the lab side, I would like to do fish at repeated intervals. And if possible, if we can have a novel transcript type for this one by means of PCR, then we can target that particular probe. We can do designing for that probe, and we can do the BCR-ABL ratio for that particular type of transcript. Otherwise, FISH is the thing to go.
Okay. So now FISH on peripheral blood or bone marrow?
Sir, peripheral blood. Sir.
Peripheral blood. Okay. Now my next question is to Dr. Amrita. Can this, how, if suppose this patient asks for a TFR later on, so how you are going to implement this? Because FISH, we know that for PCR, there are guidelines that if after 4 years of TKI therapy, if PCR is consistently significantly low with MR4 or beyond, then these patients can be given option of TFR. But in FISH, where the sensitivity of test is not that great as compared to PCR, so how you are going to give the option of TFR in this particular patient?
As per current recommendations, I think people with atypical transcripts should not be offered TFR because the method of monitoring is not reliable. There are few studies of small number of patients which can say that it can be tried, but as of now, the recommendation is if you do not have a typical BCR-ABL transcript, it's better not. It's not advised to offer TFR in such patients.
Okay. So I just want to mention about this one slide. So this is the abnormal transcript. This is another a case report published in 2017. So this is the new transcript they have described. In this patient also, FISH and cytogenetics were positive, but PCR by all methods were negative. So they did sequencing and found out that this transcript was there, E14A3. Okay, so this patient, after 3 months of therapy, the FISH test became negative. So this was on 7th June. He's still on follow-up. So I don't know, maybe in future or so, I would probably, my recommendation is to continue this imatinib therapy for long, and giving option of TFR in this patient will be difficult. Okay, so we'll go to the next case. Next, another interesting case. So this patient is 32-year-old gentleman, 1 month history of weakness, heaviness in left hypochondrium. So mild pallor was there, spleen 6 centimeter below cost margin at presentation. So this was the presentation on 12th May. This this is the differential. So the TLC was 75,000 with left shift, blast 8%, basophils 13%. And the platelets were, and hemoglobin and platelet normal. The cytogenetics 922, all 20 metaphases. PCR was positive, only qualitative was done, P210. He was started on hydroxyurea. So this is on 22nd May after 10 days when the PCR report came. So he was started on imatinib. So now my question is to Dr. Kindan. So do you evaluate any prognostic scoring system before starting TKI? And does this TKI prognostic score decides about your choice of TKI?
So, sir, actually, as I'll say that academic institute, we do scoring all the, still we are doing SOCAL also, UTOS also. So scoring we are doing, but as far as decision of type of choice of TK is concerned, it doesn't depend upon that. Usually we try to give each and every patient imatinib only, and then depending upon the response, we take the decision later on. Otherwise, all our patients go for the first generation TK only.
Okay, same questions to Dr. Govind.
Ideally, we should do the risk scoring at the time of the diagnosis. But as Dr. Kundan said there is no much practical value in starting the TK on the basis of the so-called index in our setting. So I simply start the imatinib in all patients other than the very young patients who have long survival. So without doing the risk scoring, young patient having the life expectancy more, I start the dasatinib, and other patients I start the imatinib.
Okay, Dr. Shishir.
Generally, we are doing test scoring in everyone. Since now the second generation TKI, they are generic form, they are available, well the cost. So definitely there is a means benefit of adding means second generation TKI with high risk group people. Virtually nowadays means in the practice, since there is no significant cost difference. So in young people, we generally try for a second generation TKI because they have a means deeper and faster response definitely, but means in long run means we have to see in Indian context means how it will be, but means definitely for high risk patient, we start with second generation.
Okay, so now my next question is to Dr. Prakash. So which method of investigation do you use for monitoring and how frequently do you do?
The first, though, once I have started on TKI, and then I do a peripheral blood PCR, quantitative PCR. For a typical transcript, it is IS ratio. Otherwise, it's only a PCR. I see the ratio itself. But I would like to add, sir, I do ELTS score at baseline nowadays. I have stopped Sokal and those ELTS. And if it's ELTS high risk, then I straight away start dasatinib. Otherwise, ELTS low, intermediate, I do imatinib. And for monitoring peripheral blood, quantitative PCRs.
How frequently?
Sir, first 3 months, then 6 months, as per guidelines, sir. After 1 year, no other customizations.
Okay. Same question to Dr. Amrita and Dr. Beniwal also.
So I do not use any prognostic scoring system and diagnosis. As Dr. Govind said, if it is an elderly patient, my first choice would be imatinib because all of us know that it is the best tolerated of all the TKIs compared to dasatinib, which can cause a pleural effusion, and nilotinib with its compliance issues and twice daily dosing. If the goal is TFR, if it is a young patient, if it is a woman who would probably plan a pregnancy in the future, then I would start with the second generation TKI. I do not use any prognostic scoring systems at baseline. And the method that I use for monitoring the disease is an RQ-PCR, BCR-ABL international scale, and I do it every 3 months.
Dr. Beniwal?
Dr. Beniwal has some connectivity issues.
Okay. So we'll go on to this case again. So on 30th May, the TLC dropped down to 33,000 with the differential still showing a basophilia of 7% and a blast in peripheral blood 2%. So, but he was continued on imatinib. So then on 7th June, again, this is the TLC count, the CBC showing 16,000 TLC with blast 1, promyelocytes 1. Still left shift is there and the basophilia is still persisting 6 months. So this is, we can say that after 1 month of therapy. And on 10th of July, so this is the 13,000. Again, basophils are still present 3%. So this is the recent CBC, still basophilia is 2%. And the RQ-PCR done out after 3 months. So 12th May it was started and 12th August, the RQ-PCR is showing 21.46%. So at this point of time, Dr. Govind, are you going to change therapy?
Yes, definitely I will change the therapy at the 3 months if the RQ-PCR value is more than 10%. And in this patient, the RQ-PCR value is 23%. So in this case, I definitely change the therapy to the second generation TKI.
Okay. So now my next question is to Dr. Amrita. Are you going to do the mutation testing at this point of time? Or another thing, at baseline, do you do mutational testing for every patient or not?
At baseline, I do not do mutational testing for any patient because primary TKI resistance is quite rare. But then if there is a suboptimal response in any patient and I'm planning to switch the tyrosine kinase inhibitor, then I would do an IRMA testing at that time point.
So at this point of time, how you are going to manage this patient who is having PCR of 21%? Are you going to do change therapy? Obviously, Dr. Govind has mentioned that you want to change therapy. And are you going to do mutational testing and then change therapy?
So there are some studies which say that the halving time of BCR-ABL is sometimes more predictable than the absolute value at 3 months. even though this patient will probably do poorly in the future because his 3-month time point, his BCR-ABL is 21%. And now that we have generic nilotinib and generic dasatinib available, I think I would switch. But at a point of time when we do not have dasatinib and nilotinib available in India, I think it would still make sense if this patient was observed, the 6-month time point was seen, and then you take a decision to switch. So now that we have more choices, I think for this patient, at this point of time, I would switch and I would definitely do an IRMA before I change therapy.
Dr. Kundan, same question.
Yeah, so this case, I think what my approach is that this patient has not achieved the CHR at 3 months. This is what I could understand from the peripheral blood SPR report, what we put up. So in these cases, I don't go for RT-PCR also or RQ-PCR also at 3 months. Patient who have not achieved CHR at 3 months, I'll straight away get for the IDMA testing done and we'll plan to switch over to the second line therapy, irrespective of what the RQ-PCR is. So RQ-PCR, I'll not be interested at 3 months in this case. If patient was in CHR, then RQ-PCR would have been 21%. I would have still given a thought whether I have to change or not, because usually we change at 6 months only. 3 months usually we try not to change it. For the same reason that whatever we have chosen in the beginning, we consider that that's the safest and one of the best drug. So we try to give a maximum opportunity to continue the same drug. But in this case, of course, there's no doubt at all that TKI has to be changed and IDMA has to be done, and the second line will depend upon the report of the IDMA. And maybe this case, if you have missed the doing bone marrow earlier, as many people do, then maybe bone marrow and getting the checkup for getting the karyotype done to look for any cytogenetic abnormality, additional one. So those things will be done by me.
Yeah, so I think we would like to, our time is up. It's almost, we have finished our time. So I would like to thank our panelists for this wonderful discussion. And I want to emphasize, which earlier panelists also said, that at baseline also we should do a quantitative PCR, because here we see that at 3 months time, the PCR now is 21.46%. At baseline, only the qualitative PCR was done, quantitative was not done. So we cannot say from how much level it has came down to 21%. So ideally we should do qPCR at baseline. So whenever we do qPCR at baseline, the lab always try to find out the transcript, whether it is P210 or P190. So with this, I would like to stop here. Thank you organizers thank you Chairman, Dr. Burani sir. I hand over the dais to now Dr. Burani. Thank you, sir.
Thank you, Dr. Pavan. Thank you, Burani sir. Thank you everybody.
Dr. Pavan, my one question to you. So for patients of CML at baseline, whether do you do both qualitative or quantitative?
No, we do quantitative PCR. So when we do quantitative PCR, the lab does first try and identify the type of transcript, and then only they do the rest. So in our report, that is, I'm talking about DLK, and even in Lal Path Lab also. So if you ask for a quantitative PCR, they first try and they give you the report that P210 is positive and the transcript percentage is this. So by default, it will be qualitative and quantitative.
Both.
Yes. If you ask for a quantitative at baseline, it will be, by default, it will be qualitative followed by quantitative.
Okay. So I'm thankful to you, Dr. Pavan Kumar Singh, for the excellent moderation on the topic of CML. I'm also thankful to our panelists, Dr. Kundan Mishra, Dr. Govind Patel, Dr. Shishir Seth, Dr. Prakash Singh Shekhawat, Dr. Suren Beniwal, and Dr. Amita Ramaswamy. For the next session on the topic of multiple myeloma, I invite our esteemed chairperson, Dr. Lalit Kumar sir. He is senior consultant hematologist and hemato-oncologist and bone marrow transplant physician at Artemis Hospital, Gurgaon. For second to chair this session, our second chairperson is Dr. Jirendra Kumar Perjani. He is senior consultant medical oncologist at HCG Cancer Center, Jaipur. Over to chairperson for the next session on myeloma.
Okay, so very good morning, Dr. Upen. Thank you so much for giving this opportunity, and to my greetings to my co-chairperson. So I think I just listened the previous session. It was really very well done. So thanks, Pavan, and all the panelists. It was a very nice discussion which flowed over. So hopefully we will maintain this same momentum. And to begin with, I'll request Dr. Hari Menon. Hari Menon is alumni from AIMS, and he is currently Professor of Hematology and Head of the Department of Medical Oncology. He's one of the finest person in the field of medical oncology, and has main interest has been the hem-onc. So I'm sure he's going to tell us about how to kind of personalized therapy in the multiple myeloma in modern time. Sorry.
Thank you so much. Thank you to the organizers to have me, and it's particularly gives me great happiness to have my mentor chairing the session. Learned a lot from him, and thank you for your kind words, sir. Can I share the screen? And
yes, sir.
Is it visible? Yes, visible?
Yes, sir.
Thank you.
You need to make it full screen, sir.
Okay.
Yeah, now it's.
So, thank you once again. And I was curious when I was given this topic, because it is not something, though we know a lot about multiple myeloma, how it develops. When we come to the other aspect, how much can we incorporate these understanding into therapeutic decision making? We come to the conclusion that it is important, but not up there in terms of being able to apply it to improve outcomes over and above the treatment that we already have. But it has great importance in prognosticating the disease, and also in some cases, able to determine what the sequence of therapy is going to be, because multiple myeloma, as we all know, has a remitting relapsing course, and with each relapses, we have a shorter duration of survival. So when you look at the natural history of multiple myeloma, which we alter with the treatment, we do have a pre-malignant phase. And when we actually have to treat the patient, we are able to bring it into some sort of a remission, or even for that matter, a very good remission, irrespective of what the disease heterogeneity would be, which is very typical of myeloma. And we try to get it into the lowest level of the disease status, and then try to maintain those responses to try and prolong the survival in these patients, because we know that once the patient has a relapse, the time to progression becomes shorter with every relapse. So the crux of the entire strategy would be how to prolong the survival of these patients, and these actually form the basis of selecting therapy for patients. And we all know that a good induction therapy is important. We might interchange the concept of consolidation with continuation of the same doses of induction, and we know that that improves the outcomes, and that consolidation can be in the form of a transplant. And also we choose a maintenance therapy without doubt through several meta-analysis. One of the landmark and meta-analysis did show unequivocally the benefit of improving the progression-free survival in these patients. But the problem is when we have a relapse of the disease, wherein we have a shrinking of our treatment options in these patients. So this all boils down to the biology of the myeloma, because myeloma arises from an asymptomatic pre-malignant proliferation derived from the post-germinal center B cells. And it's a multi-step genetic and microenvironmental changes that work in tandem, which orchestrates the transformation of the cells into a malignant neoplasm. And while we know that it evolves from MGUS, progressing to multiple smoldering myeloma, and finally to asymptomatic myeloma. But in between, there are several genetic abnormalities that emerge, acquired, or induced by a pre-existing cytogenetic abnormality to drive the disease forward to its eventual culmination into a more aggressive variety, and also sometimes to the other extreme of even a plasma cell leukemia. But having said that, we do have some situations where patients have what is known as a functional cure, and we encounter that more in what we call as standard risk myelomas. So what does that actually induce this genomic instability? So you have a normal cell. We do not know whether it's an inflammatory process, immune, stimulation of the immune system through an infection, which results in acquisition of certain genomic instability, translocations at the 14 locus, and deletions of chromosome 13, etc. And this moves through a phase of monoclonal gammopathy, and then comes in the microenvironmental changes, and the acquisitions of mutations, especially the NRAS, KRAS, or methylation at the epigenetic level, which eventually culminates in the development of a full-blown myeloma. And at each part of these phases of therapy, you have clonal heterogeneity, which is one of the greatest challenges in myeloma therapy. And at the level of the monoclonal gammopathy, you have mainly ones associated with the immunoglobulin heavy chain translocation and hyperdiploidy. And then as we progress from the MGUS, there are the heterogeneous changes that happen at the genomic level, structural genomic rearrangements that happen, including MIG translocations. And thereafter, you have transcriptional instability, which results in progression from a smoldering myeloma to a myeloma. And this tendency for acquisition of newer mutations and genomic instability is particularly accentuated or more encountered in patients with a high-risk cytogenetic profile. So we are always having an evolving definition for what constitutes a true high-risk cytogenetic profile. But there is a consensus on that, wherein which we will discuss in the subsequent slides. And we also know that our understanding of the myeloma has improved with the molecular analytical techniques that we have in our armamentarium, beginning with the humble G-banding karyotyping, followed by FISH, followed by the gene expression profiling, which we have been able to do, and now the single nucleotide polymorphism, wherein you are able to analyze independent plasma cells for different types of abnormalities, and of course the next generation sequencing, which looks into a host of abnormalities, including several mutations that might be acquired downstream of the genetic or the chromosomal abnormalities that occur. But broadly, when you look at the two pathways that we encounter in myeloma, they are mainly on one side, approximately 50% are hyperdiploid and 50% are non-hyperdiploid. And most of the time, these do not intermingle, but we do have infrequent intermingling of this. But what we should understand clearly is that in the hyperdiploid variant, you do not have too much of IGH translocation, and characteristically, you have the odd number of chromosomes which are hyperdiploid, encountering trisomies of the odd set of chromosomes over there, particularly trisomy 3, 7, 50, 11, and 19. But on the other end, you have the non-hyperdiploid variant, which is considered a little more aggressive, wherein you encounter gene alterations in the chromosome associated with the IGH gene, which is on chromosome 14, and these are associated with other partnering chromosomes, which result in upregulation of the genes, which include the 614, the 1114, the 1420, and the 1416 translocation. Among these, we know that this also has distinct downstream upregulation or dysregulation, where we encounter with a hyperdiploid variant mainly dysregulation of the MYC pathway, whereas with the IGS translocation, as we go down with increasing involvement of the IGS translocation, we have dysregulation of the cyclin D1 pathway, cyclin D pathway. And these mutations are primary, and then they go on to have secondary abnormalities, which includes abnormalities of chromosomes 13, 17, and 14, or it might be more adverse in the form of deletions involving the 17p and 1p. And we know the very adverse manifestation of amplification of the 1q, which can be a gain or an amplification. And then subsequently, these influence recurrent mutations, and a whole load of recurrent mutations occur. So cyclin D1 dysregulation is associated with the immunoglobulin heavy chain associated genetic abnormalities, and MYC dysregulation with the hyperdiploid variant. We also understand that the genomic architecture of myeloma, when you have the normal plasma cell and when they acquire certain mutations, there are certain mutations within the myeloma plasma stem cell. Then what we call as ancestral clones that are present in the background, which may tend to become active down as the myeloma becomes progressive, and you do have late acquisitions of abnormalities, including the 17p deletion. So clones with variable abilities to propagate, stem cells carrying initiating genetic mutations, the entire process is accelerated, particularly so in high-risk cytogenetic abnormalities as against the standard risk. And at the terminal stage, you have the 17p, T53 mutations, and which actually are more encountered in patients with extramedullary disease and terminal events such as the plasma cell leukemia, where it becomes behaving like an acute leukemia with very poor prognosis. Similarly, we know that there is an evolution of, when we look at the single nucleotide polymorphism, there's an elegant study which was published in Blood in 2012 by Keats and his team, wherein you had a baseline, and with successive therapies, there can be a suppression of a sensitive clone, whereas the clone which is already intrinsically present tends to get activated. And as you will see in the color coding over here, as we go from one therapy to the second therapy to relapse 1, relapse 2, relapse 3, the more resistant clone tends to manifest itself. And what we see on the left hand side in the blue diagram, in the blue aspect of the pie chart, which is a small slender presence, becomes the predominant presence when it manifests into an extramedullary disease or a plasma cell leukemia. So you have something which is like a progression of a disease within itself, and a heterogeneity within one cell. And this is the description of a patient from the time of diagnosis to the time of manifestation of plasma cell. And they had looked at the bone marrow samples of this patient at various time points. So what are the impact of these cytogenetic abnormalities when incorporated in the revised international staging system? We do know that the RISS gives us a bedside help in terms of prognosticating these diseases as it's reflected into this in these Kaplan-Meier curves. But when you have the second revision of the revised ISS included certain cytogenetic abnormalities, including deletion P, 414 and 1Q, over and above the ISS1 and to ISS3, wherein they gave a scoring system. And when we did that, you had a splaying of the curves with survival ranging anywhere between 34 months to that not having achieved properly those who will end up as a functional cure in myeloma to standard therapy. But it helps us to prognosticate over here. But when we include it into the addition of very high risk abnormalities to this, including IGH translocation, 1Q gain amplifications, and the chromosome 17 abnormalities, to this, we have a further delineation of the high-risk profile in these patients, which again helps in prognosticating and also to a certain extent, probably at baseline, implementing a strategy wherein you can improve the time to progression in these disease. But the problem with myeloma is that it is a constant dynamic process of evolution, of clonal evolution that happens in independent cells and within the system itself, which makes it difficult for us to actually plan a specified treatment. But we can prognosticate based on this for sure. But can we modify the therapy for high-risk group, whereby achieving an MRD would be an endpoint, because we know that MRD translates into a deeper MRD translates into better progression-free survival in these patients. But there's a difference over there too, because patients with a standard risk achieving an MRD do much better than a patient with a high risk who achieve MRD. MRD negative status, which I meant. So can we improve the induction therapy, the tandem transplant, or can we have a choice in the maintenance therapy to improve outcomes? Well, the meta-analysis as far as MRD is concerned clearly demonstrated that irrespective of among all comers, whether they were transplant ineligible or transplant ineligible who underwent transplant, the endpoint was those patients who achieved an MRD negative status had a better progression-free survival and event-free survival. And this, when applied to the overall survival, also translated into the same result, thereby saying that achieving an MRD, irrespective of what the cytogenetic profile or risk profile of the disease might be, has a benefit. So how do we achieve that? And this is again just to highlight that irrespective of the risk group, whether it is a high risk group or a standard risk group, there is a benefit for achieving an MRD, and one should strive to achieve MRD with whatever drugs or monoclonal antibodies we have in our armamentarium, which I will discuss in a short while. And this again is just a combination of the Pollux, the Castor study, the Alcyon study, and the Maya study, the first two using bortezomib and daratumumab, and the second one also in upfront setting with the daratumumab study, wherein achieving an MRD had a better outcome. This is just the Maya study, which I just took up an example to determine, to demonstrate that patients with high-risk cytogenetic profile also benefited from the use of intensification or using a monoclonal antibody along with the standard regimen, be it lenalidomide or bortezomib. But in the Maya study, it was actually lenalidomide that was used. But a word of caution saying that not all high-risk profile, but it depends upon the frequency of the high-risk profile. So you have high-risk, no high-risk, cytogenetic abnormality with one cytogenetic abnormality, more than two cytogenetic abnormalities. And so the benefit was more if the patient had less than 2 high-risk cytogenetic abnormalities versus those who had a greater than 2 high-risk cytogenetic abnormalities, which translated into a better progression-free survival. And patients who, if you look at it, if patient had just 1 high-risk cytogenetic abnormalities, the use of daratumumab allowed for responses that were almost equivalent to that with the standard risk profile over here. So similarly, so there's a signal over there that perhaps that use of monoclonal antibodies or using a quadruplet regimen may translate into better outcomes in these patients. But the studies are ongoing to prove this point. Secondly, can we change the maintenance therapy? As I said, it goes without saying that for standard risk profile, maintenance therapy with lenalidomide is standard, and that has been reflected in the 3 meta-analysis, including more than 1,000 patients, which reflected a benefit in terms of improved progression-free survival and overall survival. But can we change the cytogenetic abnormalities? So this is the HOVON study, which looked at using bortezomib as maintenance therapy, clearly demonstrating that there was a benefit for patients who had high-risk cytogenetic profile, in terms of improving their progression-free survival. So the Emory group, Sagalonial and his group, have gone one step ahead, showing that if you have more than 1 cytogenetic abnormality or more than 1 high-risk cytogenetic abnormality, including a triplet regimen as maintenance therapy would be better than using a singleton maintenance therapy in these patients. So it has gone one step ahead. I'm not shown the graph over here, but there is data to support that if you have higher cytogenetic abnormalities, use of a triplet maintenance therapy would benefit in these patients. Similarly, can we change the proteasome inhibitor? There were only some signals as far as the FORTE study. The FORTE study was not designed to demonstrate differences between high-risk cytogenetic profile. It was designed to demonstrate whether autologous stem cell transplant versus using KRD limited had a benefit. And clearly, there was a benefit for those patients in terms of achieving a better progression survival and higher MRD negative status for the KRD arm, followed by an autologous stem cell transplant. And it also translated into a better progression-free survival. But if you look at this forest plot, you will understand that there was a benefit for the high-risk cytogenetic profile, which is what we are discussing now. So that's the purpose of me talking about the FORTE study. Maybe, again, that was probably got to do with the additive effect of the transplant over the backbone of the carfilzomib lenalidomide dexamethasone regimen. More so, the study emphasized the benefit of transplant in these subset versus not doing a transplant in these group, and probably the high-risk cytogenetic profile in the subset analysis also derived benefit. Similarly, there has always been the debate of transplant, the tandem transplants, and the French group have
kindly conclude your talk in 2 minutes, please.
Way back in 2013, they were demonstrated that patients who had more than with high-risk cytogenetic profile, particularly the 17p deletion, benefited with a tandem transplant. So we may want to consider and strategize our treatment based on the type of based on the cytogenetic profile, based on the high-risk cytogenetic profile to improve outcomes in these patients. The only thing that might just actually talk to us about is the benefit of actually targeting myeloma, which is a BCL2. And we saw that the BCL2 overexpression resides in patients who have the 1114 translocation. And this was what was explored in the Bellini study, which looked at patients with 1114, which is encountered in about 15% of the patients. And clearly, those patients wherein we used to target against, which is venetoclax against BCL2, we had almost a doubling of the overall response rates in these patients. And mind you, these were patients who had failed 2 to 3 lines of therapy. Currently, this was the protocol where people had failed 1 to 3 lines of therapy, and clearly those patients who had the 11-14 translocation had an improvement in distinct improvement in the progression survival and an overall survival too, but though it was not as good as the progression-free survival that we encounter. So, so exploiting other targets have also been used in myeloma, and these include the FGFR inhibition, which allows the dysregulation of the Sept. Again, the translocation 414, including in the translocation involving 414, and inhibition of the FGFR3. We have a molecule called erdafitinib, which targets and the combination of erdafitinib with ixazomib is ongoing to see whether those patients with FGFR3 mutation, which is commonly encountered, will result in responses in these patients. And the cyclin CDK4 and the 6 inhibition have not been so encouraging, but the use of abemaciclib is being tried in the My Drug Trial study to look at patients in the relapsed setting to see whether patients who harbor this inhibition of this pathway will translate into benefit. There's another one called the Sept D2 methyltransferase, and exploring the epigenetic mechanisms in myeloma for benefit. So in conclusion, I would say that multiple myeloma is clinically and biologically heterogeneous disease. Bulk genomic studies have revealed the presence of clonal heterogeneity, which is consistent. Despite the genetic architecture of myeloma, precision therapy is still probably a long way off because of the heterogeneity that is involved in the myeloma cell, within the cell and within the system itself. And by targeting tumor and immune cells, probably is a way ahead. Precision therapy is coming in some way in myeloma therapy, but having said that, I haven't discussed CAR T-cell therapy because it was beyond the scope of this talk, but targeted therapy, it is a targeted therapy, but it is a global kind of a treatment targeting the BCMA, which is expressed in almost all myeloma cells, and irrespective of the cytogenetic risk group, and they do have a uniform response, and that has been clearly shown in the 3 studies using CAR T-cells, all the 3 phase 3 studies using different CAR T-cell cells. And so with that, I will conclude with this talk, and I'm happy to take any questions. Thank you.
Thank you, Hari. It was a very nice talk, and summarizing all the developments which have taken place in the field, and particularly with the emphasis of the high-risk cytogenetics and the MRD. I'm sure there must be a few questions from the audience. So please unmute yourself and just ask questions if there are any. Meanwhile, Hari, can I ask you, like, I would have
yes, sir.
Like that, maybe you could have to make it personalized, like suppose sometimes people come in the practical sense, like suppose if you have a person with the XMLD disease, like how do you approach to this patient compared to another person? High-risk cytogenetic you have covered, like what should be the standard of care for induction. And so sometimes we get the plasma cells in the peripheral blood, 2%, 3%. So these are some of the practical issues which we get in the clinic every day. So how do you really...
So when you go back on the cytogenetic abnormalities, the extramedullary disease, etc., and even the plasma cells, whether it is primary or secondary cell plasma cells in the circulation, always invariably harbor the cytogenetic abnormalities which are associated with high risk profile, and they have a lot of RNA abnormalities also, which which results in drug resistance to these of the myeloma cells to standard therapy. So almost always when we have these patients with extramedullary disease or plasma cell leukemia, or for that matter, circulating plasma cells, they are high-risk disease. But having said that, you are unlikely to treat them differently, but you would use the same kind of in the frontline setting. That's what I mean. You would use the same kind of strategy, like including a quadruplet regimen or using daratumumab in the treatment of these patients for better outcomes. But having said that, you don't treat them any differently other than to be able to prognosticate them as likely to have an early relapse with standard therapy. Yeah, and remember, much of the patients with who were included in the CAR T cells did not, where the plasma cell leukemias and those with extramedullary disease were actually excluded from those trials. So we are still yet to know as to what would be the impact of those strategies in treating these patients. And there is the data now coming up, which is also going as part of the clinical trial, wherein we are using a frontline therapy of CAR T cells in high-risk myeloma patients. So that would be probably a good study for us to answer what we do with high-risk patients in terms of having a better outcome, because uniformly they tend to relapse.
Okay. Thank you, Hari. Thank you so much. And maybe since time is a little short, so I'll request my co-chair to introduce the next speaker for his second talk.
So Dr. Jiten is not there.
Oh, okay.
So you can continue, sir. Thank you.
Oh, okay. So our second talk is on the monoclonal antibodies. This is one of the area where we really had last 4 or 5 years. So much has been said and so much has been talked about. And I request my next speaker, Dr. Rajesh Patil. Are you going to talk?
Yes, sir.
Yes.
Yes, I'll share my screen.
Highlight, enlighten us about all this aspect.
Yes.
Especially with the Indian setting, like how really cope up with this, the cost issue.
So today's talk is on the maximizing the depth of the response with the monoclonal antibody in the frontline setting in myeloma management. So as we heard from Sir, that achieving MRD negative state is more or less important in myeloma, because we all know that myeloma disease there is always tendency to relapse. Yeah. So myeloma, once we treat the myeloma, there will be a period of remission, which depends on the biology of the disease. The high-risk patient might relapse early. We have to achieve as deeper remission as possible, and then there will be definitely a relapse, and the relapse will goes on, and this is ultimately leads to the relapse and refractory state. So we all know the general treatment regimens for the transplant patient, where we give induction therapy and transplant, consolidation therapy used in many of the regimens, followed by the maintenance, while it is directly induction therapy followed by maintenance for the non-transplant eligible patients. So what are the pillars of therapy in multiple myeloma? We all know that our routine treatment mainly consists of the proteasome inhibitors, mainly bortezomib, IMiD, mainly lenalidomide, what we use, and steroid, dexamethasone. Many times we use the cyclophosphamide in cases of renal failures. So monoclonal antibody, which is commonly which is available at least in India at present, is IV daratumumab. Other therapies are not available with us. So we can see how the use of that therapy can improve the response rate. So daratumumab, we know it is a humanized antibody which targets anti-CD38. As the trials have shown by Sir, there is a Pollux and Castor trial which shows that in combination with Len and Bote, it is effective therapy for refractory settings. As it is it binds to the malignant cells which expresses CD38, and through mechanism of antibody-dependent cytotoxicity or complement-dependent cytotoxicity, through mechanism of antibody-dependent phagocytosis, it leads to the plasma cell destruction and reduction in the plasma cell load. So in frontline setting, the approved indications, as we know that it is in combination of lenalidomide and dexamethasone on the basis of the MAIA trial. It is in combination of the VMP regimen, which is not at present commonly used, bortezomib, melphalan, prednisolone. It is in the patient who are not eligible for transplant. While in patients who are eligible in transplant, as per the Cassiopeia trial, the bortezomib thal-dex is what the commonly used regimen, but we all know that when bortezomib len-dex as to the Griffin trial is the indication for upfront settings. So I'm just going to go through quickly in these settings, and then we can discuss how we can use this in our setting. So in 2018, the trial has published Alcyan trial, which has showed that there is overall survival when we add daratumumab to the VMP regimen. So protocol, there was a randomization, VMP regimen was there, and there is an addition of daratumumab to the VMP regimen. And we can see there is a daratumumab, which is also kept as a maintenance here. While here VMP regimen, there is no maintenance, even bortezomib has stopped after 9 cycles. They look whether they can get PFS and overall survival benefit with addition of daratumumab. So Dara here in induction setting as well as maintenance setting, what we can say, versus only VMP of 9 months. So definitely, as expected, the significant overall response improvement was there, 90% overall response with addition of Dara compared to the 73% of VMP. CR and the stringent CR rate we can see in combination, which goes approximately around 40%, while it is approximately 25% in combination of the VMP. And MRD negativity rate is also significantly better, which is around 22% as compared to the 6% with only VMP. So it is long clear that there's a significant improvement in response rate and MRD negativity is achieved with the addition of the Dara. As we know that they have given it induction and they continued Dara in maintenance, so it has paid a significant benefit. We can see after the study protocol is over for VMP, there is a downhill course for the VMP, while the Dara addition of Dara has maintained the response, and this has reflected in the significant PFS improvement, and with hazard ratio of 50%, means 50% reduction in the risk of the progression, which is quite significant in addition of Dara in induction and maintenance. The similar improvement they are able to show that with hazard ratio of 0.6 in the overall survival. So with this, they have shown that the Dara addition of Dara has in induction and continuing as a maintenance had shown in PFS and overall survival. Regarding side effect, in most of the all studies, like Alzheimer's study, MAIA study, Cassiopeia, mild neutropenia, URTI, and pneumonias are relatively more than what are the control group, and some infusion-related side effects are expected with the daratumumab. Coming to the next study, as Sarah has also discussed, Lendex, which is a standard of therapy in the elderly people. These people have combined the daratumumab, the trial published in 2019. With the simple randomization, here the Lendex, which is a continuous therapy, what we can say, until progression, which is better than what we can say in VMP, while here the Dara, which is given in induction, and then it is also till progression disease. It is also continued as a maintenance, and lenalidomide is also continued till the maintenance. So even in this, as compared to the Lendex, which is significantly better, we can say 80% overall response rate. DRD has shown more or less similar response rate as we have seen in Dara VMP, around 92%. What we can see, the stringent and complete response and complete stringent was significantly better than, there is no comparison here, but we can see it goes approximately 50% here. Around 47 people have 47%, there is CR or better response rate. Well, MRD negativity rate is more or less same, which is around 25% as compared to Dara VMP. But when we compare to the here control arm, we can see in each aspect, overall response, the CR response or MRD negativity, significant improvement. So addition of Dara has paid off here also. So in elderly people, there is a significant improvement. We can see in the deepening of the response, let it be a stringent CR, complete CR, all kind of responses improved by the addition of the daratumumab, which has leads to there is improvement in the progression survival. Here we know that the Lendex, they have continued as maintenance, and here Dara was in addition, and the progression-free survival is significantly better. We can see with hazard ratio of 0.56 here. Coming to the overall response, even overall response has also improved with around 32% of reduction of risk of death in addition of because of addition of the daratumumab. In 2022, they have given little bit updated analysis of this thing. So what we can see here is coming to the discontinuation rate. So that's what little bit frightening for me, that for the Lendex around 85% as a discontinuation rate was there, while it was 64%. I'm not sure why there's a difference in this, and that might be because of the progression of disease and adverse effect that has led to the significant more people to leave the trial in Lendex. So when they updated analysis, they have seen the overall response is more or less same, but what we can see, the achievement of response, like CR or better than CR, is significantly better. It is now, it has crossed 50%, it is around 51% here, and it is 30% in Lendex. And MRD negativity rate has also significantly improved from around 24%, what was before. Now it is 32% versus 11%. So, updated analysis has reconfirmed that there is significant PFS improvement with addition of the Lendex, with 45% reduction in the risk of progression of the disease, and with the overall survival benefit also retained on that further analysis. Coming to the use in the transplant setting, autologous transplant setting, combining daratumumab to the VTD regimen. This is done in Europe. The study is done in Europe. So that was the first phase 3 trial to evaluate daratumumab in transplant eligible newly diagnosed myeloma patient. So here they have given 4 cycles of either VTD or combination of Dara VTD before transplant, then 2 cycles as a consolidation post-transplant. This is a part 1 of the Cassiopeia, where they have evaluated the response after end of induction, after transplant, and post of consolidation in terms of the MRD negativity and achievement of the CR rate. So what we can see here, that addition of the daratumumab has significantly improved the depth of the response post consolidation. Overall response of 93 versus overall response of 90, which is as good, equal. But if we see the response equal to or more than complete response is 39% when we add the daratumumab versus is 26%, which is significantly better. And we can see at the initial phase, like at the post-induction, the achievement of the stringent CR and CR might be more or less similar, like here 7% versus 7%. But as we go post-transplant and post-consolidation, this response gradually depends and improves with period of time. And this has reflected in the PFS benefit with around 53% reduction in the risk of progression and death as with the Dara VTD compared to the only VTD in this thing. So as the median OS was not reached in this treatment of that they cannot shown that there is actually overall survival benefit, but the hazard ratio at in end of consolidation is 0.43%, which is significantly better still. So further part in the same trial was the second randomization, where those people who have achieved either minimum partial response, they were randomized to receive daratumumab maintenance versus only observation. So like this is the baseline trial what we have seen, and here the second randomization happened for the daratumumab for till progression, means at least 2 years, like maximum 2 years they have given. After that, only observation was there versus observation. So this was the second randomization in this, and what their aim was to see for the PFS benefit, of course, and what was the MRD negativity rate in these peoples. So what they have seen that when the addition of daratumumab, the achievement of the CR rate or more than the CR rate is significantly better. And similarly, it has reflected in the MRD negativity rate also. And after putting daratumumab maintenance. So we can see here the various combination DARA in induction, DARA in maintenance, DARA only in induction and observation, VTD in induction and DARA in maintenance versus VTD induction and observation. So only VTD versus and then no maintenance is not at all a good choice, as we all know at present. While more or less using daratumumab at any stage of the therapy, either induction or maintenance, looks the more or less better option. And what we can see that the maximum benefit is in daratumumab used in induction as well as in maintenance. Though there is difference is not significant in these both arms, where daratumumab, if used upfront and if they are not given in maintenance versus observation. So there is a PFS benefit. They have shown that 47% reduction in risk of disease progression or death when daratumumab used in the maintenance thing. So this is the diagram which shows that 3 overlapping curves, like where the DARA is used in the induction or VTD used in induction, while the daratumumab is used in the maintenance arm, while DARA VTD, there is observation. They're more or less like overlapping. So DARA either at induction or maybe at least at the maintenance has definitely helped, while the arm where there is only VTD and no observation, which is not even standard at present, because at least some kind of maintenance with bortezomib or len is always given. So this is might be an inferior mark, what we can say. So lastly, coming to the now what is what currently all what we are using the RVD with addition of the daratumumab. It is the here also the scheme were more or less same. All the newly diagnosed myeloma patient received 4 cycles of RVD with or without daratumumab, then post transplant 2 cycles, and then there is a maintenance which goes for the 2 years. So after 2 years of maintenance, the patient they can take as per the local whatever the treatment of choice can continue lenalidomide. So here also the same thing what we have seen the RVD versus DARA RVD. What we can see the darker thing is the achievement of the stringent complete CR. So the chances of achieving CR or better than CR is significantly better. That at the end of 2 years of the maintenance, what we can see, there is around 83% chances versus it is 60% with only using the RVD. So there is a significant difference in achieving the CR or better than CR rate when daratumumab is added. And the similar effect is shown in the MRD negativity. When the 10⁻⁻5 is taken as a cutoff, so what we can see is the 64% people have achieved MRD negativity, while it was 30% when using only RVD regimen. So here what we
Kindly
can show that
conclude your talk in 2 minutes, please.
yes, done. So here what we can show that when 10⁵ MRD cutoff is kept, the MRD negativity is achieved very fast when addition of DARA versus when the DARA is not used. Which has reflected in the PFS benefit, as we can say, but overall benefit is not demonstrated, maybe because there are multiple second line and third line treatments are available, and event-free survival is improved in the addition of the daratumumab. Side effect point of view, there is a little bit more neutropenia, more URTI, as we have all seen in all the daratumumab containing arms. So thank you very much for the patient listening. So all these 3 to 4 trials are showing that MRD negativity is better in the when we use the daratumumab in the upfront setting. But I have a little bit this thing that the comparator arms were there. They have not used the maintenance in some of the thing. And actually daratumumab is also not used in the maybe the relapse setting also. That might be also the one thing which might showing the overall survival advantage in the Maya and the VMP arm. Thank you very much.
Sir, whether you are there? Lalit sir?
Sir, you're mute.
I think Dr. Lalit is not there.
Okay, sir.
So I thank Dr. Rajesh for
Dr. Lalit sir is there, sir.
Yeah, I'm here.
Yes.
So thank you so much, Dr. Rajesh. That's a very nice overview on the daratumumab trials, which you have really given very nicely discussed. The only thing, like in our Indian setup, we find it difficult to use it as a routinely in the first line treatment, which ideally should have been there. It's mainly the cost region. So any efforts to, given the low dose daratumumab, any idea, any experience people have, any individual and in the audience who may have tried in the low dose and see if they still achieve the response and MRD negativity, because that at least may bring down the cost. Otherwise, we find it really difficult to accept very few patients. Most of them find difficult actually.
So I think, and there is one more thing in sir, in this, like in relapse setting, there in no trial they are allowed to use daratumumab. Like what we can see, either use daratumumab or there is no daratumumab at all. That kind of scenario, daratumumab is definitely trumps. But like if those patients who have received RD or VMP, if they relapse and if they use daratumumab, there might be no overall survival difference.
Right. So I think thank you once again, Dr. Rajesh, and we'll move to the third talk by Dr. Mallikarjun Kalaseti. And they're looking forward for his talk. He's going to give us a pragmatic and adaptive approach for the treatment of relapse and refractory myeloma. This is something which we all really find difficult to handle some of these patients when they come with relapse. Dr. Mallikarjun.
Yes, sir. Good afternoon, sir. I hope my slides are visible and I'm audible.
Yes.
Yes, sir.
Yes, please.
Yes, sir. At the outset, I would like to thank Dr. Upendra Sharma for having given this opportunity and for having conducted this meeting. And just want to caution the audience that he's much better looking in person than in this picture. So I would be speaking about relapsed multiple myeloma over the next 15-20 minutes. There are lots of slides, so I'll run through a few of them. So we have heard from our esteemed speakers already, the paradigm of myeloma treatment is such that no matter what we use, current day and age, the treatment is not curative in intent, and relapse recurrences are a rule rather than an exception. And we also know that we used to debate this several years before, should we save the best treatment for the last? But the answer is clear and in our face, that as the disease relapses and recurs, there is a clonal evolution, and the disease is likely to become more refractory, more resistant, and patient is likely to become more frail and not being able to take most treatment. So what is also very important for us to remember is, as patient goes from one line to second line with multiple relapses, there is a significant patient attrition, and oftentimes many patients may not even get to the next line of therapy because of more reasons, much more so in our country because of the financial constraints. So it is our responsibility to try and treat them well whenever we can, so that the remission, whether it is a CR1, CR2, is as long as it can. So again, we don't have to go through the definitions of progression. So any rise, more than 25% rise of paraprotein, plasma cells, extramedullary lesions, or even circulating plasma cells is a relapse. And we define a refractory, primary refractory, relapse refractory based on when the patient relapses, whether they achieve any minimal response or whether they are having a progressive disease all along during the treatment. So it is also important for us to define a clinical relapse, which conventionally we were doing with the CRAB criteria, because biochemical relapse in itself need not be an indication for therapy during the relapse of this multiple myeloma. One must also be careful that the relapses can occur differently than the disease at the presentation, and patients may present with extramedullary disease. And like we have doubling time in most lymphoproliferative disorders, a rapid doubling of paraprotein is also indeed an indication, so that we don't have the patients suffering because of the disease burden and target organ damage. And at relapse, again, it's amply clear that patients who have a long remission, those who have remission lasting for more than 2 years, regardless of the cytogenetics and risk stratification at the baseline, are likely to do better at relapse. On the contrary, those patients who relapse within 12 months of initial therapy, regardless of their initial cytogenetics and FISH abnormality, are likely to have an aggressive disease post-relapse. So this is, again, we have seen this as the patients have 1, 2, 3 relapses, it is likely that the disease burden increases, clonal evolution worsens, and the disease is likely to become less and less responsive to the best of available treatments that we have. So when we decide about treating patients of relapsed multiple myeloma, we not only look at the disease biology, but also look at the fidelity score, look at the patient's performance status, look at their comorbidities, try and take history of prior therapies, how well they treated prior therapies, did they have any significant toxicity, can we choose the agents based on the prior therapy is extremely important. And one must never forget to include the patient aspirations and the family's aspirations with regards to how they want to treat, how they want to be treated. Do they want purely oral medication? Do they put more impetus on quality of life, pain-free, or are they trying to do more and are indeed agreeing and are accepting the risks that come with more intense treatment? So re-evaluation should be done systematically, like we do in the upfront treatment of multiple myeloma. Look at the paraprotein burden, look at imaging if one has to do aspiration and look for clonal evolution. And one must never remember that the patients may have different presentation at relapse. And assessment of organ system, perhaps geriatric assessment is extremely important when one is dealing with old patients. So previous therapies have to be looked at and try and choose a medicine, at least 1 or 2 medicines from different classes that the patients have had previously. Look at the adverse events that the patient has had, try and choose the protocol wisely, which can be both effective and less toxic for the patient. So also one must look at the transplantation. When was the if the patient has had autologous transplantation in the past, and when was it done, so that one can decide about whether one can undergo a second transplant. So the principle that we use are always look at the duration of initial response, which kind of defines biology at relapse than anything else. Try and choose triplets over single or 2 agents, as this is likely to be more refractory. And again, we have given the reason, try and choose the best drug soluble rather than keeping them for later relapse. And if there is a choice, at least 1 or 2 drugs from the non-refractory class would be extremely helpful. Consider the performance status, age of the patient, comorbidities, and the patient aspirations when you choose. And prior toxicities must always be looked at when you choose a newer treatment protocol at relapse. And once you initiate treatment, one must treat to maximum response and continue the therapy till the progression or intolerability, because patient is likely to relapse again. So the early relapses, the first question we almost always ask is the patient LEN refractory or LEN intolerant, or is the patient LEN sensitive? Because most of the protocols that we have in LEN sensitive individuals would have lenalidomide as a part of triplet or quadruplet, whereas the patient is refractory to LEN, who try and choose DARA-based or proteasome-based protocols so that the patient can achieve another deeper remission. So if the patient has had up to 1 to 3 lines of therapy, again, try and use monoclonal antibody if the patient has not received that previously. But sir has already mentioned the challenges. These are prohibitively costly for most of our patients who tend to pay from their pocket, and weekly cost is anywhere between 2 to 2.5 lakhs. So that is the biggest deterrent for widespread usage of monoclonal antibody. And if the patient have already had exposure to monoclonal antibody or are LEN refractory, then the challenge becomes more. And some of the medicines are not even freely available in our country, but one should try and choose a protocol which the patient has not been exposed to. So when we treat patients with relapsed refractory multiple myeloma, we are very aware and mindful that one size does not fit all, and multiple things will have to be looked at in choosing a protocol for these patients. So we'll go through a few trials. Again, I think all of us here know that if the patient has had no DARA exposure, and whenever DARA was compared, for example, in this Emory experience where they added DARA to POMDEX, it was seen that patient who has standard disease did much better in terms of both PFS and also duration of the median PFS. So when the DARA was then added to POMDEX, again you see DARA arm did much better than patients who received non-DARA, and I think that is quite clear. So if the patient has had no DARA exposure in the upfront treatment, when it is used with any of the agents that are being used at the relapse, the outcome is likely to be better in the DARA arm. So I think we all talk about POLYX study, and it was very clear that a statistically significant and clinically meaningful OS benefit was seen in DARA with Lendex compared to Lendex alone. And there was a 56% reduction in risk of disease progression or death in DARA Lendex compared to Lendex alone. and higher proportion of patients achieved MRD negativity in DARA Lendex. So, and it was also well tolerated compared to the control arm. So this is something for us to see if patient has had no exposure, and if we can try and give them a monoclonal antibody. Again, so the role of maintenance of carfilzomib has been debated. It's not an easy agent to give long-term maintenances, but at least in few trials, it has shown that maintenance with carfilzomib is superior, at least in terms of prolonging the median progression-free survival across the board, as can be seen in this forest plot. So a few cautions about anti-CD38 monoclonal antibodies. There is indeed increased risk of infection. One must make sure we look at the hepatitis B core antibody before we start. And if the patient has core antibody positivity and HBsAg negativity, they would need hepatitis B prophylactic therapy. Zoster reactivation, hypogammaglobulinemia are something which to be looked at, and oftentimes vaccination post-DARA might be less effective. Blood grouping, cross-matching, antibody screening are indeed very important before starting, as it interferes with grouping and cross-matching. And infusion-related reactions, all of us are aware, and we use appropriate treatment medications, at least in the initial few infusions. Autologous stem cell transplantation, I think time and again it is proven its efficacy in the frontline treatment of patients of multiple myeloma, despite the presence of 10 or new agents. Even at the relapsed patient who have never had autologous transplantation are fit enough, should be given a choice and chance of having an autologous transplantation, as it will indeed deepen the remission. And lack of response to initial transplant does not preclude transplantation if the patient has had good therapy at relapse and if is in deeper remission. And those who have had at least 2 to 3 years of remission with the first transplant can safely be given a second transplant if they can undergo one. I think this is a very controversial topic, and we have been debating for several years. I don't think that we use allograft much in a patient of multiple myeloma, but it can exceptionally be used in a very young, very high-risk multiple myeloma patient who have a suitable donor. Of course, having explained to the patient and family about high risk of transplantation-related mortality, the wish is that the graft versus myeloma effect might put some of these patients into long-term remission and perhaps in a potential cure, but it comes at a cost of immediate toxicity, perhaps including risk of life to these patients. Now, in further lines of relapses, I think there is a whole new era with plethora of agents being available, but I'm afraid most of this would be a theoretical discussion for our patients because of prohibitively high cost. However, we'll anyway go through those. So penta-refractory disease is a bad one, wherein the patient has progressed on all the available treatment protocols that we have. So if a patient in multiple lines of refractory disease has non-penta-refractory myeloma, one should try and use the agent that he's not exposed to. But if it is indeed a penta-refractory, then we do not have too many choices, but to look at the CAR-Ts, the BiTEs, and the other newer agents. So most of the immunotherapy in multiple myeloma is targeting the BCMA, whether it is CARs or BiTEs or even drug immunoconjugates. So BCMA is expressed nearly on all myeloma cells, and it is implicated not only in disease proliferation, but also drug resistance. And the wish is, by blocking the same, we may improve the efficacy and make the cells more susceptible for cure and kill rather. So these are the various BCA targeting newer agents that we have. Drug conjugate, essentially the payload which is released based on the BCMA binding in this cancer cell would lead to cancer cell death. And belantamab is one which has been studied in DREAM-1, DREAM-2, and it had shown good efficacy indeed in terms of overall response. But because of keratopathy, which is commonly seen with most drug immunoconjugates, this has not been widely used. And because the DREAM-3 did not meet its primary endpoint, I think there is some challenges for this medicine for being widely used in relapsed refractory multiple myeloma. CARs are the new things, and we all know CAR is an exciting way of treating many relapsed refractory hematological malignancies. It essentially combines the best of B and T cell, so it has the advantage of target specificity of a monoclonal antibody and yet retaining the cytotoxic effect of intracellular T cell domain. So we essentially take the patient and try and collect the cells, which are then engineered to express anti-BCMA epitope on them, and then the same cells are expanded and infused into the patient, and then that is how we treat. And most of the CARs in myeloma are BCMA CARs. So what we know is two of the ones that we are which we use across the world, ID-cell and CITA-cell, and KarMMa phase 2 study which looked at the IDCL, wherein the CARs were given at 3 different doses, and the response was unprecedented really in this multiply heavily treated myeloma patients with overall response rates of about 80%, and that led to the approval of ide-cel in relapsed refractory multiple myeloma. So similarly, CARTITUDE study studied the ide-cel in patients of relapsed refractory multiple myeloma. Again, these patients are heavily pre-treated, and as you can see, again, the response were quite unprecedented in this heavily treated patient. That led to and what is also was very clear was the response were seen in both high risk cytogenetics, high ISS status, and regardless of prior therapy. And this was very clearly seen that CAR-T might overcome some of the high risk features in these heavily treated patients of multiple myeloma, and that led to its approval in relapsed refractory multiple myeloma. So if you see the overall response rates in some of these groups of patients who would otherwise have had no option really are very impressive indeed. The only challenge though is to make these immunotherapy modalities widely accessible for most of our patients. A few caution of CAR infusion, try and do it in centers which have some experience, but then all of us will have to learn on the job. We must not use a leukodepleting filter when we infuse them. Try and use steroids because that might prevent the proliferation of T cells. And again, one must watch at least for the first 1 to 2 weeks for the cytological, the cytokine release syndrome and neurological complications that may happen with CAR infusions. Bispecific T cell engagers can be off the shelf. Again, they would target the PCMA, and the advantage of BiTE perhaps over the CAR T cell is if they are becoming available off the shelf, at least the waiting time in those patients who have aggressive disease and who cannot wait for 4 to 6 weeks, BiTEs might be more appropriate in such individuals. So teclistamab is one of the BiTE that we have, and it was studied in the Majestic trial. And again, you see very impressive response rates of 63% with these, and the progression-free survival and OS are quite impressive indeed. But the challenge though is making them available, and overall response rates of 60% in this subgroup of patients is extremely impressive indeed. So CARs versus BiTE, I think there is no comparison in the sense CAR T cells likely to be more effective and perhaps one and done and unmatched progression-free survival. Only thing is manufacturing time, access, and the cost. On the contrary, bispecifics can be off the shelf and can be easily given to patients who need it immediately. But then patients may not have the long PFS that we see with CAR-T. But again, cytokine release syndrome and other immune complications can be seen with both modalities of therapy.
Sir, kindly
yes.
conclude your talking.
So I'm done. So novel therapies, I think, are much more impressive in terms of efficacy and depth of response, though we don't see plateau and treatment-free long remissions are not there. Cure is not there on the horizon just yet. So selection in multiply treated patients, the first question we want to ask is, are they penta-refractory or not? If they're penta-refractory, you would want to see whether they have received any BCMA-directed therapies or alkylator-based therapies. If not, you try and use them. If those have also been used, then it's a real challenge, and we may have to use the BiTEs, which are not widely accessible. So at relapse, we must try to reevaluate, review, and re-stratify them and look at the prior therapies. Try and use the best available treatment rather than saving it for a heyday. And again, a combination of agents, newer classes, and non-exposed medications might be better in this relapse group. Old conventional treatment may still have role, though CARs are likely to be the future. So personalized, risk-adapted, and precision medicine is a way forward in most hematological malignancies, and I think that is a way for multiple myeloma too. I stop there and thank you for patient hearing. I'll hand over the podium back to the organizing team.
Lalit sir, whether you are there? Lalit sir? You can unmute Dr. Lalit. You have to unmute yourself, Dr. Lalit.
Can you listen now?
Yes, sir.
Yes, sir.
So thank you, Dr. Mallikarjun. So I missed the last 2 minutes, actually. There's some network issue. So it's a very nice overview. This is one of the very important area, relapse refractory myeloma, which really poses difficult problems, especially if somebody you have followed for a number of years and suddenly comes with a relapse. So I have 2-3 points which I thought would like to share. One, that biochemical relapse is not so uncommon, at least in 5 to 10% cases. And if carefully, if you monitor them, and a very small early evidence of relapse, maybe with a median of 6 months, patients can go on without much deterioration. So that is one aspect. Secondly, when we decide for treatment, especially for elderly individuals, I still feel that the two drug combination is still one of the important regimen which could be used. And because there is really no randomized trial for the elderly, especially people who are above 70 years, giving 3 drugs, sometimes toxicity can go up. So that is another thing. And of course, the steroid are still very, very important drug. And sometimes if you're not using proper dose of dexamethasone, that can also be a problem. Sometimes we underdose also. So that is, but then we have to be careful. And fourthly, especially in our setup, like where we cannot afford daratumab and other newer drugs for many of our patients, especially in the public hospitals. What I feel like the regimes, the older regimes like DT-PACE or DCP, they still give you the good remission, provided you follow them with this thing. Or I think there is need for developing a oral combination. And one of the combinations simply would be like cyclophosphamide, oral BP16 and dexamethasone, with or without thel or lenalidomide or pomalidomide, could be a good metronomic kind of regime, which could be used for some of these patients who have a probably slow disease biology, not very aggressive. So they can work and give you good time for couple of months people can go on before you can plan out some of other things. The other, I think Dr. Rajesh did a nice job summarizing the daratumab data. And of course, Hari gave a very nice, excellent overview with the high-risk cytogenetics and its implications in the day-to-day management. So with these words, I like to thank Dr. Upendra for giving the opportunity and all the speakers for the brilliant job. Thank you so much.
Thank you.
Thank you, Dr. Rajit, for chairing the session. And thank you, Dr. Mallikarjun, for that wonderful talk, as always. Thank you, Dr. Rajesh Patil and Dr. Hari Menon for your excellent talk. Now I invite Dr. Bausa Begal. He is Professor, Department of Medical Oncology at prestigious Tata Memorial Hospital, Mumbai. He will be moderating a panel discussion on management and treatment of relapsed refractory multiple myeloma. Over to Dr. Bausa Begal. You can introduce your panelist.
Thank you, Dr. Upendra, for this invitation, and I hope my slides are visible. I'm audible. At the outset, I'd like to thank my panelists, Dr. Naveen Gupta, Dr. Pankaj Tantia, Dr. Akanksha Garg. I think Dr. Nivedita Dingra couldn't join us today, and my colleague, Dr. Sumit Merk from Mumbai itself. Our goal is to see go into granularity. What is a relapse? What kind of relapses you get, as Lalit sir said, serological versus symptomatic. What evaluation we do at the relapse, and after that we will go on to the management, specifically what factors you consider, what commonly regimen we use in our setup, role of transplant, and some different treatment options. So I'll start with a case. This is a real world case which I am treating recently. She is a 55 female fit. She presented with rib pain and swelling. She just had a IgG kappa M band of 1.54 gram per deciliter, and her light chains were normal. We didn't do her urinary BJ protein. She had a ISS3 and RISS3 with a presenting feature of anemia and bone disease. She did not have any hypercalcemia or renal disease. Her LDH was 210, slightly elevated above the normal of our lab for 190. PET scan showed lytic lesion with associated soft tissue component. Her fish showed a translocation 4 coating along with a 1Q gain. And she was treated with VRD with zoledronic acid. After third cycle, her M band came down to 0.5 gram, which technically is partial response. And she was continued on VRD after this. We looked at her M band after three more cycle, which is 0.8 gram per deciliter. So we have a young fit person with multiple myeloma, and her M band is 0.5 at the end of 3 cycles and 0.8 at the end of or at the 6th cycle. So with this background, I would like to start with my panelist. I think I must appreciate the presentation done by Mallikarjun. I think it was a very good presentation. He covered all the points. So we will try and go into the practical aspect of management rather than theoretical point. So first question, I will start with Dr. Naveen. How do you monitor your patient who has been treated for first-line therapy for a possible relapse? What tests do you order, and how do you approach such patients? Dr. Naveen, you are there? Or maybe someone else can take this. Am I audible?
Am I audible now? Am I audible?
Yes, Naveen, you are audible now. Please continue.
Yeah, sorry for the technical issue. So with regards to monitoring a patient on treatment, so it requires monitoring in terms of both clinical as well as the biochemical parameters. So whatever was the initial clinical presentation, like in this case, if you have anemia and bone lesions. So for bone lesions, I think just the symptomatic assessment of the patient often tells us whether the patient has any improvement or not. The diffuse bone pains would usually go away after a cycle or two, and the anemia is also expected to recover. And the monitoring of M protein or light chain, whichever was found to be involved at the outset. My practice is to do assessment every 2 cycles and to look at the trend. So that's
yeah. Thank you, Naveen. So Naveen, in terms of monitoring the M band, what do you consider individual patient? Do you individualize? For some patient you monitor with only electrophoresis, for others you looked at light chain? How do you choose what test you want to do at the end of 2 months?
So, as with a lot of us, because the cost of the treatment, the cost of monitoring is always a consideration. So, if a patient has a detectable M band at the beginning, I would monitor only with the M band till a point it becomes undetectable, and subsequently we may have a light chain escape. So, subsequent monitoring, I use free light chains in such patients. And if a patient only has an isolated light chain disorder to begin with, then the monitoring is by light chain assay.
Yeah, correct. So I think point was to we will require different monitoring strategies for different patient. We'll move on. What will be your approach in this patient which we discussed, Dr. Pankaj? She has a rising M band on 0.6 to 0.8 at the end of 6th cycle. What will you do next? Or maybe Dr. Akanksha?
Yes.
Yeah, Pankaj, tell me.
Am I audible?
Yes, you are audible.
If it is increasing 0.6 to 0.8, I think I will. How much cycles we have given?
6 cycles. So after the 3rd cycle, she had a partial response, 0.6, now 0.8.
Partial response, yes. So basically, this is a partial response. We can go for another investigation, scanning and all, to see whether there is a new lytic lesions or not, because it is a very small difference from 0.6 to 0.8. I won't be in a hurry to consider it as a refractory disease. So I will go for other investigations to prove whether it is a relapse or a refractory disease right now.
Yeah. I think very well point made by Dr. Pankaj that these M bands, they have issues with sensitivity, especially at the lower levels, and we should be taking into consideration these definitions of relapsed refractory myeloma, which requires a bit of going them again and again so as to make us familiar, but it is important they are there for some reason. So Mallikarjun covered them very nicely. And relapse comes in different varieties. Some people are relapsed, but they are not refractory. Some are relapsed and refractory, and some people are refractory to begin with, those called as primary refractory. And all these people would have different prognosis, and hence different management will be required. And our patient doesn't meet a criteria of progression more than 25% increase with at least increase of 0.5 gram per deciliter. and obviously she doesn't have these clinical features. So the point was we have to make sure that we are looking into these guidelines, and these are relapse and refractory. Refractory is someone who progresses on treatment or within 2 months of the therapy, and primary refractory is person who doesn't achieve even a minimal response and then progresses. And Mallikarjun also showed serological significant progression where treatment might be warranted. So doubling of M-band within 2 months or increased by 1 gram per deciliter within 2 months, and similarly urine BJ protein more than 500 and a light chain increase of 20 milligram per deciliter in the difference. So as we discussed, we'll move on to the pattern of relapse. Some people have different kinds of presentation, and this is a very a kind of informative study. As Lali sir were saying, some people would have serological relapse. So this panel group looked at 200 patients over 18 years of period who had relapse after transplant. And what they have seen is half of distribution serological relapses were 49 and symptomatic relapses were 50%. People with serological relapses tend to have late relapses, while symptomatic relapses tended to do early. And the pattern of relapse was similar to how do they presentation. So basically, we had to see what the problem was in our individual patient. And these are symptomatic relapse. So Lalit sir exactly pointed out within 6 months, these people required the treatment, and 26% of them didn't go on to treatment for 2 years. And the characteristics were early stage ISS disease. They didn't have any extramedullary disease, and the M-band was IgG type. And when we monitor, most of these people did not develop any end organ damage. While symptomatic relapse, they had a higher ISS, they had higher plasma cell infiltrate and higher anemia in the baseline. So these are some of the pointers we need to monitor. And in terms of outcome, these people have different outcomes. Symptomatic relapse tend to behave badly as compared to serological relapse. And this is also seen in the recent subgroup analysis of Endeavor trial. So if you look at the people who are on the left side who had symptomatic relapse, this KD did not have any overall survival benefit, but there was a benefit in people who were having serological relapse, pointing to the fact that no timely treatment of these people is important. So we move on. What evaluation we consider in treating a relapse patient? So maybe Dr. Akanksha.
Yes, sir. Sir, at the time of relapse, if I'm suspecting in a patient, then I would again go for the clinical evaluation. So that will be the presence of, sometimes the patient complain of bony pain. And along with that, I would like to do certain investigation in the form of doing the renal function testing, along with the, sometimes in some patients, even repeat PET CT can be done to evaluate and compare with the previous report. And as far as the biochemical parameters are concerned, then I would again go for a full myeloma panel where I would do a serum electrophoresis, fixation and free light chain assay. And in certain selected patients, maybe a bone marrow can be done, but that is not always my practice to do bone marrow in all the patients, because we know that most of them are quite these patients are elderly, and it is not very easy to do repeat bone marrow examinations in these patients.
Okay, so I think Dr. Akanksha has covered everything. I think some of the people would have circulating plasma cells, so it is important to look at the differential count. Also LDH, which will give us an idea about the aggressiveness of the disease. As Dr. Akanksha said, bone marrow cytogenetics may not be always necessary, but some additional cytogenetic abnormalities may be done, looked at into them. And one thing is, many times our patient have not undergone a cytogenetics at baseline, so we may want to do it if to see if there is something to target upon. We'll move on to Dr. Sumit. Sumit, what factor you consider for deciding treatment for a relapse patient when you decided to treat a patient, Sumit?
Sir, am I audible?
Yes.
So there are multiple factors when you have to decide on treating for a relapsed patient. The most important factor is whether he needs treatment or not. There may be asymptomatic biochemical relapse patients where the physician may choose to observe. And I know biochemical relapse is a gray zone where two physicians from the same institute can also differ with respect to their decisions.
So Sumit, Sumit, one question: what biochemical relapse we should be treating, or what you will prefer to treat biochemical relapse?
So if it's an aggressive biochemical relapse where there is a 50% rise in the M-band on 2 consecutive measurements.
So that
so within a period
serological
of 8
aggressive.
weeks.
Okay.
Yes,
All right.
if there's
Any
a
other
rise in the
situation?
light chains, if there is a prior history where the patient had presented with renal dysfunction, in these patients, if the light chains are going up, I'll be more careful and wary. If there's a prior history of baseline presentation of fracture, I'll be more careful in these patients that they're not debilitated at time of relapse. That's it. And when you have to consider for treatment decision, it is primarily depending upon what prior treatments the patient has received, what all he has been exposed to, what all he has been refractory to. If there is a progression within 60 days, then it is a priority refractory to that respective line of treatment. What is the performance status in front of us of the patient with any comorbidities like neuropathy or cardiac issues? And most important, the patient preference. At times, we have patients who come back from long distances who may not prefer to take injectables like carfilzomib, daratumumab, and especially the finances. So majority of these factors.
Yeah. So I think Sumit has covered, and for the sake of simplicity, we can divide this into host-related, tumor-related, and treatment-related factors. And definitely, this is important. This will give a lot of information what to do and what not to do. When you look at the treatment option in a say guideline or algorithm, we are confused. There are too many options. But when you have a patient in front of you, unfortunately or unfortunately, you are left with very few options. Another factor which Mallikarjun showed was the attrition rate. And as you could see, this is the same presentation which he quoted, and roughly 1/3 of the patient do not receive second line treatment, and the attrition is even higher at the next line of treatment. So you should be using your active regimen. That's one message. And this is from the Western countries. The similar is data from the Australia, and I believe there's a publication from US also. But the attrition in our country is likely to be much more. So we should be treating these people with the best available regimen earlier on therapy. Another question which comes is, as Sumit highlighted, refractory versus number of lines of therapy. And most of the studies will use number of line of therapy. But there are two recent abstracts and publications from the last ASH which point that we should be looking at drug refractoriness rather than the prior line of therapy. And this publication from Dr. Costa's group, it beautifully shows that number of line doesn't matter. So what they have done is they have taken patients who are not refractory or they are single class refractory, and they are compared. So double refractory and triple refractory has a very impressive hazard as far as overall response is confirmed, but number of line doesn't matter. And in terms of progression, the same thing. If you have triple class or double class refractory, your PFS is likely to be very short. But there is no division in terms of prior line of therapy. So this is an important message coming up. There is a similar publication from the Mayo group as well. And in this publication, they show that these people who are triple refractory, their PFS is 3 months. If they are double refractory, it is 6 months, and it is roughly 18 months if you are not refractory or single class refractory. This kind of should help us to choose a regimen in our practice. So what happened is, as Dr. Pankaj pointed out, this lady had a very small disease, but we did her PET scan because we are not comfortable with this M-band going up, and she was completing 6 months. So we wanted to see, so we did a PET scan that showed a progression in terms of plasmacytoma. So we'll move on. Means how will you treat this patient individually? So the first case scenario is someone has undergone a VRD, auto transplant, and a maintenance line and progression. Let's say at the end of 24 months. So Dr. Naveen, what regimen you will use in this patient?
So if a patient has maintained a good disease-free interval of 24 months, one of the option is to re-challenge with the same agent. So we can use bortezomib again in these patients. The patient has been on LEN maintenance. If you ask me in like a clinical setup, borti, pomalidomide, and dexamethasone would be something that I would start with. Obviously, for all of these, DARA remains an available option, but since because of cost and financial constraints, that's not so readily used. So, Borti, Pom, Dex for the first scenario, that's something that I would use.
Yeah, so that's the choice, Pankaj. What will you choose, Pankaj?
Sir, may I please know the history of the patient again?
So this is a patient who has received VRD, has undergone autologous transplant and LEN maintenance, and has progressed after 2 years of maintenance.
2 years of maintenance. So patient had a long-term maintenance on lenalidomide. So I would consider, as Dr. Naveen said, we can give pomalidomide-based treatment in this. and then we can do again auto transplant.
Okay. Yeah, I think that's important thing to remember. She has a very good PFS in this case. So
Yes.
Sumit and Akanksha, do you differ as far as regimen is concerned in this patient? Any comments? If you differ, then otherwise it's okay. We'll move on to next question.
So similar to Naveen, VPD is an option because bortezomib is not being given for 2 years. Any of the DARA as well as carfil-based regimens will also be an option. One option which we have used at times, which is a completely oral regimen, is form cyclodex.
Yeah.
Especially if the patient doesn't prefer to take any injectables.
Yeah, I think that's a good option. So that's as Lalit sir said, quite a handy option in our setup. Any a difference, Dr. Akanksha?
No, sir, I think I would also prefer adding a pomalidomide-based therapy, and the second agent can be either we can give the bortezomib or choose cyclophosphamide along with dexamethasone.
Yeah. So I get your point, and most of our patients will not be affording daratumab. But in terms of choosing the treatment, if let's say there are no financial constraints, I believe all of you would go for a regimen like Dara, bortezomib, dexa, or Dara, carfilzomib, dexa, right? Because it's a lane refractory patient, and POM would be a useful option, but definitely not a preferred one.
Yes, sir. If the cost is not an issue, finance is not an issue, definitely daratumab would be advised for in this patient.
Yeah. So I will show some slide to that effect. Let's say this person is only treated with VRD, has not undergone autologous transplant, progression on LEN maintenance. Now the situation here is different. Person has not undergone autologous transplant. 2 reasons: ineligible. There is no question of autologous transplant doing. But if someone is eligible, and which is a common situation in our country, so how do you treat this patient? I'll start with Sumit this time. Sumit.
So, so this patient has relapsed after how much duration LEN maintenance in
again
scenario?
Sensitive, very good PFS.
Assume 2 years. So again, same as in the last case, we have DARA-based options, carfil-based options, bortezomib, POMDEX, POM cyclodex. If she's fit this time for an autologous transplant and willing, salvage auto also remains an option. Upfront salvage auto is not done commonly in our setting, but once they achieve a response to some kind of salvage therapy, then we have considered auto in CR2 or any second response in such patients.
Correct. So that was my purpose. If someone's M-band is rising, will you take the patient directly for auto, or you will give salvage? So you answered that you wanted to give a salvage and then do transplant. Okay. Now the next difficult to treat person like this individual patient is progression on therapy, and let's see what choices we have. So maybe one word answer. Naveen, what you will do? Person is progressing on treatment VRD.
Similar to the case that you have presented, if the patient is progressing on VRD, so a young patient who's otherwise fit 6 cycles and is showing frank progression, this would be a point where I would strongly consider changing the class of drugs and maybe introduce DARA right away. A DARA-based regimen to bring the patient under a good disease control and immediately proceed to an autologous transplant. That's something that for this patient.
So maybe DARA KD or DARA POMDEX, those kind
like
of things.
So DARA POMDEX, and as soon as we get a response, we go for an autologous transplant. If she's 55, otherwise no comorbidities, she will be a good candidate for transplant.
Okay, all right. I think we are short on time. So I will. One thing is most of our patient will progress on LEN maintenance, and there is some thought whether it is refractory or not refractory. We covered this. We'll use combination therapy, newer class, next generation drug on the same class. We'll keep in mind the extramedullary disease, which is not really sensitive to these drugs, and consolidation with autologous transplant and progression therapy. This study shows pomalidomide treated a patient when they progress on LEN full dose versus a LEN maintenance dose. So there was no difference in the progression-free survival, and the refractoriness at lower dose correlates with the refractoriness higher dose. This is sketchy data, but definitely something to keep in mind. These are the different options which we went through. These are the studies which are in the LEN refractory patient. And one thing is, there is a nice editorial commenting on how to use these studies in the clinical practice. If you look at the performance of the control regimen, it was vary from 7.1 months to 15 months. It all depend upon how many patients were len refractory. And in len refractory patient, the PFS was 6 months, while studies were len sensitive, it was quite high. So that's something which we have to keep in mind. One thing which Rajesh discussed and pointed out was use of daratumab early in this patient, and Pollux trial indeed showed overall survival difference. He pointed out the caveats of this analysis, but definitely looking at the way daratumab works and data from the other study, earlier use seems to be better for daratumab. We discussed about the salvage autologous transplant, and anything you want to add here, Sumit?
Salvage auto means in second response, so same as what I told before.
All right, so definitely something to consider in our patient population. It basically depends upon the duration of initial response. If it is less than 1 or 2 years, you may not want to use the same transplant again, so you may skip it. Intermediate, you have to decide. Definitely a sensitive relapse more than 3 years. This is post maintenance, so definitely you will want to do it. And this is the UK myeloma 10 study, which definitely drives our decision to do transplant. It showed a survival advantage as compared to a cyclophosphamide-based continuation of therapy. And it showed that it works in most of the subset. There are very small patients in the high risk 414 and fish high risk category, but it looks like active in most of the patients. We'll move on and we'll talk briefly so as to we complete our discussion about CAR-T, monoclonal and bispecific. What do they differ from the currently available regimen is in terms of response rates. So response rates are definitely high, and CR rate, especially the CAR-T and the bites are definitely in the range of 50 to 60%. So there's something active. Given no financial limitations, when would you choose ADC, bite, and CAR-T? So we'll start with Naveen. Naveen, you can tell.
So even in the West right now, most of these newer therapies are indicated in patients who have failed on 3 or more lines of treatment. So even if there is no financial limitation, particularly I would prefer in patients who are young and who have had aggressive disease. So we do get a lot of such patients in our practice who are in their mid 30s or early 40s and otherwise physically preserved, but the disease biology is bad, and we have multiple early relapses after several lines of treatment. So those would be ideal candidates for either one of these novel therapies, or maybe if we want to experiment with an allogenic transplant. So these are the group of patients progressing on 3 or more lines, young patients, very aggressive disease, early relapses. This group of patients is where I would like to use.
So I think Naveen has nicely summarized it, and he also has brought out a very important point that if someone becomes refractory in earlier lines of therapy, but because of the labels of this drug, he will not be eligible. So there is a artificial vacuum created in these people. They have to receive some unnecessary or useless lines of therapy before they become eligible in the Western population. And we know that looking at these drugs activity, they seems to be active. So belantamab for median PFS of 18 months. We looked at talquetamab median PFS of again similarly 18 months, and we looked at the CARTITUDE CAR-T median impressive PFS of 36 months, and this was after median 4 lines of median 6 lines of therapy. Aprol is after 4 or more lines of therapy. And they are challenging our concept, relapsed multiple myeloma CAR-T versus standard of care. All of us are aware about CARTITUDE-4 result. And this study showed that in this len refractory patient population, which is commonly a clinical problem nowadays, CAR-T outperforms the salvage regimen in this study. So definitely this is something to look at. What other options we have, Pankaj? Our patient don't have these drugs. Anything else you use in your practice?
The last, but not the least, I would try bendamustine in such patients, or venetoclax like drugs.
So benda, venetoclax. Akanksha, anything else you have used or you want to use?
So like we have the classical, the melphalan based, and those agents can also be used, especially patients who have already received the previous therapies and they don't have access to these novel therapies, and we can use melphalan based.
And many times they are not undergone transplant, so melphalan is an important drug, I think. Sumit, any other drug you think of when
in venetoclax? Otherwise, PACE like we use in PCLs,
correct.
plasma leukemias is in.
So those are the options. So the drugs which were tested were selinexor and other drugs. Any opinion about selinexor? Maybe Sumit, let's say we have feasibility of using selinexor. Would you consider? What's your take on this drug?
So I have not used it. The PFS is encouraging. The differences by a period of say 5 to 6 months. The only issue is the GI toxicities. So if given a chance and is available, I might use it for a patient.
All right. Yeah. So very modest activity response rate of 30%, PFS of 3 to 4 months. Definitely not really satisfying. So these are the drug, I think, venetoclax, bendamustine, selinexor, plus minus, and definitely, as Lalit sir said, chemotherapy like DCAP, etc., not to be forgotten. We'll speak about venetoclax. So we know that this is useful in LN14 or BCL2 high expressing patient. But what we have recently started doing is the split. As you could see, the activity is much more in the 11-14 patient, and non 11-14 and non BCL2, the activity is not there. So what we have recently started is looking at the sensitivity by looking at 11-14 in this patient or prior or at the if not available, then we repeat a bone marrow, and also look at the venetoclax sensitivity score. This is easily doable. So what this paper from Dr. Vikas Gupta has shown is if these cells express B cell markers on the flow, you could come up with a score, and these people, they fall into that subgroup of Bellini trial who are likely to derive the benefit. So this is something handy and which we can consider in an individual patient. So I think we will conclude here, and I will like to state that relapsed refractory multiple myeloma is a heterogeneous patient population. We should have a plan for monitoring our patient. Timely therapy is important, and salvage regimen has to be individualized, as Mallikarjun said. Refractoriness seems to be more important than number of lines of therapy. Active salvage regimen and consideration for autologous stem cell transplant in our patient population is very important if they are not undergone it earlier or they are transplant sensitive. And there is promising data with immunotherapies, and hopefully we'll have access to this soon. So with this, I will stop here, and I will thank my panelists and everyone, and back to organizer. Thank you.
Thank you, Dr. Bausa Begal, for that excellent moderation on how we can treat relapsed refractory multiple myeloma patients. I'm thankful to our panelists, Dr. Naveen Gupta, Dr. Pankaj Tatia, Dr. Akanksha Garg, Dr. Smith Bin, for their discussion on this how we can treat relapsed refractory multiple myeloma patients. So today we had discussed about what has happened at EHA Frankfurt, Germany from 8th to 11th June this year. And today we had eminent Galaxy speakers. We have discussed various aspects of hematology covering CML and multiple myeloma. First talk by Dr. Chandran K. Nair. He talked on how we can improve eligibility and success of TFR in CML patients. So we can achieve TFR in about 45% of patients. Criteria for this include TKI duration more than 5 years, prolonged EMR more than 2 years, patient motivated, and having willing for frequent monitoring. Those are the subset of patients, and this has been shown in the Eurosky trial also. He showed that STEM trial, those patients who are in low Sukal risk score have 60% chance of attaining TFR as compared to 10% chance of attaining TFR in those patients who are having high risk of Sukal score. He also showed that faster responses and deeper responses were more with second generation TKI as compared to imatinib, and innovative approaches combining TKI with JAK inhibitor, or combining with BTK inhibitor, or combining with BCL2 inhibitor as venetoclax as newer approaches in subset of patient where we are thinking of TFR. Second talk by Dr. Riaz Ahmad. He talked on CML unmet need and treatment landscape. So he showed that failure rates in later lines of therapy were around in the tune of 80% in third line setting. He also showed that off-target effects of kinase inhibitors can impact safety of the drug with higher discontinuation rate in those patients who are having TKI intolerance. Treatment goal is to improve the quality of life, attaining early molecular response, deep molecular response with the goal of attaining TFR. He also showed that there a need for newer treatment options in patients with T315 mutation. As we know that patient who are having T315 mutation is a death sentence for those of most of our Indian patients, because we're not having presently any currently available medicine. Ponatinib is not available in India. Asciminib is a new horizon. Some of these patients, they are getting through compassionate program through Novartis. He also showed that deeper responses may be associated with improved outcome with better DMR and TFR rates and disease reduction in disease progression and improved survival. Then we had a panel discussion done by Dr. Pawan Kumar Singh with excellent discussion on the by panelists on the topic of CML. Then we had a talk by Dr. Hari Menon. He talked on applying personalized medicine to multiple myeloma patients from bench to bedside. He showed that primary and secondary cytokine abnormalities in multiple myeloma patients can impact our treatment and prognosis. He also showed that the evolution of newer clones and clonal selection leading to drug resistance and disease progression is more in patients of high-risk multiple myeloma. So by modifying therapy for high-risk group patients, we can achieve deeper responses. He also explained the role of MRD in management of multiple myeloma patients. Phase 3 HOVON trial, wherein bortezomib was used as a maintenance in patients with high-risk multiple myeloma having high-risk cytokine abnormalities, showed better benefit. He also showed the role of tandem transplant in high-risk group with TP53 mutation and those patients who are having translocation level 1114 as the abnormality. Then we had a talk by Dr. Rajesh Patel. He talked on how we can maximize the depth of response with MAP in frontline setting in treatment of multiple myeloma. So we can improve, we can have improvement in deeper responses and overall response with better PFS and OS benefit when DARA is used upfront. Then we had a talk by Dr. Mallikarjun Kalashetty on how we can treat relapse refractory multiple myeloma. He showed that, we should use our options, better options upfront. So with each, we know that with each relapse, duration of remission decreases. So we have to give better treatment options, whether we are treating patient upfront or in the relapse refractory setting. We also talked about the role of CAR T-cell therapy and the role of BiTE therapy with teclistamab in relapse refractory setting. Lastly, we had a great panel discussion by Dr. Baudas Bengal and our other panelists. I'm also thankful to my patron, my teacher guide, Dr. Faraj Ijna Madam, for her blessings. I'm also thankful to all the chairpersons, the speakers, moderators, panelists, all the delegates, all the students, and all the participants who had attended today's meeting and making us a great success. I'm also thankful to my scientific partners, Johnson Johnson, Novartis, Pfizer, and Viatris for making this event a grand success. I'm thankful to all. Over to Tarunji.
So thank you so much. I think the day 2 for Hematology Express on EHA 2029 was an excellent success with the support of everyone. And we propose to thank Dr. Upendra Sharma sir for conceiving and convening this program. And thanks to, as you very well said, thanks to all the faculties, panelists, participants for this wonderful webinar. So all of us from the organizing team, my colleagues, Abhimanyu, Nishan, a big thank you to each and every one of you. Have a nice Sunday and looking forward for many more. So thank you so much to everyone. Stay safe, stay blessed. Thank you till we meet again.